And then we have also discussed about this Yersinia enterocolitica, and we have discussed that it causes a pseudoappendicitis because it causes the inflammation of the ileus. And you know that ileus is very close to the appendix, so it will mimic as the appendix pain. But when you do the endoscopy or the CT MRI, your appendix would be normal, and that's how you know this must be a case of Yersinia enterocolitica. We have discussed that it's a gram-negative rod, and how you can get this disease by either the contaminated milk or the pork, or might be the pets like puppies. Okay, there's one more disease with the Yersinia, and that is Yersinia pestis, which is a gram-negative Coccobacilli. And remember the fact about this bacteria, that it exhibits this bipolar staining. Very important thing. Remember the Medusa head colonies in the gram-positive bacteria, the Medusa head colonies.
Bacillus.
Anthesis, yes, Bacillus anthesis, and the bipolar staining in the Yersinia pestis. So they will appear as this safety pin-like bacteria. Okay, and how they will how you're able to acquire the infection through the rodents or the rats or the mice. Okay, and there is a flea which resides on the rodents or the rats, and by this flea bite you can acquire these infections. Okay, so if you come into contact with the rats or the rodents, and then their flea might bite you and you can get this Yersinia pestis infection. What they call it is known as a buboes, which is a painful swelling inguinal lymph nodes. Painful inguinal lymph node swelling is the buboes. So you will get the fever, you will get the chills, and you will get a very painful swelling at the inguinal region. And it is responsible for the bubonic plague. If you guys remember about the bubonic plague, it is a Yersinia pestis who does that. So what does it causes? The lymph node inflammation that leads to the buboes formation, which is a painful swelling inguinal lymph nodes. Very important. If I didn't mention it, so you can write it down in the first aid. Then comes the lactose fermenting bacteria. Like we already discussed, that MacConkey agar actually used to differentiate between the lactose fermenting and the non-lactose fermenting. And I have told you about this Seek mnemonic, which is the which is all the bacteria that ferments the lactose. That includes your E. coli, Enterobacter, Klebsiella, okay, and Citrobacter. And then you need to know about just one more agar, which is a sorbitol MacConkey agar. It is especially used to differentiate between the E. coli species, especially for the enterohemorrhagic E. coli. Every other E. coli can feed on the lactose as well as on the sorbitol, but this enterohemorrhagic E. coli cannot ferment the sorbitol. So the EHEC species will form no color in the colonies, while the other species will lead to the change in the color of the agar. So that's how you know this must be the case of enterohemorrhagic E. coli. Please remember this name, sorbitol MacConkey agar, very important. And then there is one more agar, which is the eosine methylene blue, EMB agar. Remember I told you already in the very initiation part of this microbiology that this EMB agar in the E. coli will form these green colonies, which is which is formed as this green sheen, while the other bacteria, the other lactose fermenting bacteria, they form this blue or purple or the black colonies. So that's how you can again differentiate. So all these three medias, the MacConkey agar, the EMB agar, and the sorbitol MacConkey agar, they are all the differential medias because they are helping in differentiating between the different species. Okay, so that's about it. Then we're moving to a different species of the E. coli. And before we test it, we need to know certain properties of the E. coli, and it is gram negative. Very important, they are indole positive. Okay, they are gram negative, indole positive rods. And step one gonna ask you about different proteins they have and how does they cause the diseases. Okay, so fimbre or the pillais, they are responsible for the cystitis, which is UTI, and the pyelonephritis, which is inflammation in your kidneys through this cystitis also, right? So fimbre, they basically help the bacteria to attach to the mucosal surfaces or your urinary tract. So if the step one asks you how you're able to acquire the UTI through this E. coli, you will answer the fimbre because they help in the attachment of the bacteria. Okay, then comes the K capsule. And remember I told you, if you have this K capsule, if you have the capsule in the bacteria, then the bacteria are able to enter your bloodstream, right? So this K capsule actually responsible for the pneumonia and the neonatal meningitis or the bacteremia. Okay, so because of this capsule, the E. coli is able to invade your blood system and can cause the pneumonia and the meningitis. Then comes the LPS endotoxin, and you already know its function. It is responsible for the septic shock. And they will ask you what part of this toxin, endotoxin, is responsible for the septic shock, and it is the lipid A. Very important, okay? And one more thing I told you about, in the gram-positive part, when we're studying about this saprophyticus infection, I told you that all the gram-positives are nitrite negative, but the gram-negative bacteria are nitrites positive. So whenever the question stem gives you something about the UTI, and they will give you that these bacteria are nitrite positive, you will immediately know that they're talking about the gram negative bacteria, which could be your Klebsiella, which could be your E. coli, which could be your Proteus. Okay, and if they told you that these bacteria are nitrites negative, you will immediately know this might be a case of either the Enterococci or might be a case of your Staphylococcus saprophyticus. Okay. Then different strains of the E. coli. First is the entero-invasive E. coli. As the name suggests, they invade your GI system or the intestinal mucosa and causes the necrosis and the inflammation. And because they're invading your GI mucosa, they will cause a bloody diarrhea. Okay, they will cause the bloody diarrhea, just like your Shigella. Okay, so they will invade your GI system and can cause the dysentery-like disease. You will get the bloody diarrhea. And what you will get in the stool examination, this would be a WBC is very high leukocytosis, and because you're having this bloody diarrhea, you will have this erythrocytosis, also high RBC count. Then enterotoxigenic E. coli, and they basically act through the toxins. The toxins we have already discussed about the heat labile toxin and the heat stable toxin. So what they will cause? No inflammation and no invasion, just the effect of toxins, which causes the watery diarrhea. Remember, the chlorine secretion would be increased in case of heat labile toxin, cyclic AMP, and the absorption of the chlorine would be decreased in case of heat stable toxin, which is your cyclic GMP. And they will cause a traveler's diarrhea, the enterotoxigenic E. coli. So because you are not having any kind of inflammation, so no leukocytosis would be seen, and you're not having any bloody diarrhea, so there won't be any erythrocytosis. Okay. Then comes the enteropathogenic E. coli, which causes the pediatrician diarrhea. They cause it diarrhea in the children's. Okay, and uh, they do not form any kind of toxin. Okay, so no toxins would be there. They just act like the viruses. They will cause the flattening of the villi. They will destroy your villi and lead to the malabsorption. They will prevent the malabsorption. They will prevent the absorption, so causes the diarrhea. And remember, I told you the location of this lactase enzyme. Remember, in the biochem section, we have discussed about the lactase enzyme, and we have also discussed the lactose intolerance. So after the infection of this enteropathogenic E. coli, you are likely to have this lactose intolerance because you're destroying your villi where the lactase enzyme is present. Okay, so once the infection is over, you will get another diarrhea, and that diarrhea is because of the lactose intolerance. Then comes the enterohemorrhagic E. coli, and especially you need to know about this strain 0157H7 because it causes the hemolytic uremic syndrome, and it has a toxin just like your Shigella-like toxin, which causes the inhibition of the 60S subunit of the ribosome, and as a result, you will have the loss of protein production, and as a result, the cell death will occur. Okay, how you will acquire the infection? By the undercooked meat. It could be a case of the hamburgers that contains the meat. Okay, and you need to remember and yeah, just like the shigellosis, you will get the bloody diarrhea in case of enterohemorrhagic. As the name suggests, hemorrhagic, you will get the hemorrhagic diarrhea, bloody diarrhea. Okay, and you need to remember about the Shigella-like toxin, which causes the 60S subunit inhibition that leads to the inhibition of protein synthesis. And you will also get the hemolytic uremic syndrome because this toxin is this toxin would also act on your blood vessels, and it is very toxic to your blood vessels, causing the microthrombi formations throughout the blood vessels, especially your kidney part. They will cause the microthrombi formation in the renal blood vessels, and you will get the renal failure in case of enterohemorrhagic E. coli, and it is the hemolytic uremic syndrome. So a classical case would be a patient who is having this bloody diarrhea, a child who is having the bloody diarrhea, and after the bloody diarrhea, he's having this oliguria and this flank pain, or might be this high level of the creatinine. Okay, and they will ask you what is the reason behind it, and it would be the acute kidney injury due to the formation of microthrombi. Okay, and because of the microthrombi, you will also get the cystocytes, which are the destroyed RBCs. They have the shape like this helmet shape. You will study that later in the hematology section. These are your cystocytes. These destroyed RBCs, they have this any shape like that. What happens is when the RBC pass through a thrombi, let us suppose this is your big thrombi that form after the EHEC infection. This is your RBC passing through this thrombi, and while passing this RBC will destroy and attain this cleaved shape, this very dysmorphic and abdominal shape while passing through this microthrombi, and that's why you will get the cystocytes in case of the enterohemorrhagic E. coli. Very important. So the classical case, in this case would be a patient who is having the history of diarrhea. Now he's having this oliguria and this high creatinine count, and on the PBS, what you will get these cystocytes and the anemia, of course. Okay, and of course, during the formation of this microthrombi, you will get the platelet this consumption. So you will also get a thrombocytopenia. So a case would be anemia, thrombocytopenia, and the renal damage and the diarrhea, bloody diarrhea. This would be the case of this enterohemorrhagic E. coli. Please remember. Any doubt in enterohemorrhagic E. coli? How will get the infection? Very important. Undercooked meat or the hamburgers. What it will cause? The bloody diarrhea, then the kidney damage, then the loss of RBCs, loss of platelets, formation of the cystocytes. These 4 points are very important for it. And what you will get in the stool examination, you will get the erythrocytosis, and of course some WBCs are also there because they do not invade your GI system. Very important, they do not invade the GI system. It's just a toxin which is causing the every effect. Okay, so a toxin alone. While the Shigella, you will get the toxin and plus the invasion. And in case of entero-invasive E. coli, you will get the invasion but no toxin. Any doubt? Anyone? No. Okay, then we will study about this Klebsiella. And the only thing that you need to remember about this Klebsiella is this aspiration pneumonia, and one more thing is the nosocomial UTI. Okay, so these are the gram-negative rods, and they are the part of your intestinal flora. And what they will cause is the lobar pneumonia in the alcoholics, diabetes, or might be the patients with seizures, or the old age patients, or might be the patients who lose their consciousness for some time because they causes the aspiration pneumonia. With any of these things, if you are the alcoholic, then you're likely to get the loss of consciousness, or might be the seizure patient, or might be the old age patient, or might be the patient who is having some kind of a paralysis of their GI part of their mouth. So they're likely to get the aspiration pneumonia. Okay, and they will aspire this Klebsiella. So the only case you will get about this Klebsiella is the aspiration pneumonia. So if the question is time, do not give you any kind of history like like the seizures or the alcoholics or the diabetes or the paralysis type, you will not suspect the Klebsiella because you will not get the aspiration pneumonia in that case. Okay, and they will form very mucoid colonies. Very important. They will ask you about this mucoid colonies part because they secrete the polysaccharide capsules. Okay, they have very thick, very abundant polysaccharide capsule there, and that's why their colonies are very mucoid, as you can see here. These are the colonies of the Klebsiella. They also causes the nosocomial UTI, like we have discussed, the Proteus, the Klebsiella, and Staphylococcus saprophyticus. They are the most common causes of of the UTIs overall. And Klebsiella, Staphylococcus saprophyticus, and Proteus can also cause the renal stones. We have discussed that already. And yeah, and along with the aspiration pneumonia, you will also get the abscess. Why? Because you aspire the oral contents, you will also aspire some other anaerobic bacteria along with the aerobic bacteria, and these anaerobic bacteria will also causes the abscess formations. So aspiration pneumonia and abscess formation would be there. It could also cause a nosocomial UTI. What you will get are the very mucoid colonies, 5 mucoid colonies, because they have very thick polysaccharide capsule. Okay, so most probably they will give you a case of alcoholics, or they will give you a case of seizures, or a patient who is admitted in the hospital who is out of consciousness, or the patient uh, who is having the paralysis of their mucosa. Okay, only then you will suspect the case of this aspiration pneumonia. Okay, and it just not the Klebsiella, but also bacteria like Streptococcus would be there, and other and other anaerobic bacteria would also there in this case of aspiration pneumonia. Any doubt? Anyone?
No, sir.
Okay, so then we discuss about this. Just a second. The Campylobacter jejuni. You need to know uh, what are the reservoirs of this Campylobacter jejuni, and these are basically your pets, the poultry, the chickens, okay, the hens, and this could be a pet like a dog, okay, like cats, like pigs. So with these animals, you are able to acquire this infection. So remember the dogs, the cats, the pigs, or might be the chickens, hens. Okay, so they will give you the history of some kind of pets or some kind of a farm worker. Okay, and then you need to know how to identify these organisms. You need to know that they have this polar flagellum, which is a flagellum on one side of the bacteria, and they are the curved gram-negative rods, very important curved gram-negative rods having a polar flagellum. Okay, and one of the very characteristic feature of these organisms is they grow at a 42 degrees centigrade temperature. Very important. They grows at a 42 degrees centigrade temperature, and they require very low oxygen condition to grow. And it is known as a micro aerophilic conditions. Very important micro aerophilic conditions. They require very less oxygen to grow. They're oxidase positive. They have this S-shaped with polar flagella, which is a flagella on one side of the bacteria. And of course, they are curved or comma shaped or S-shaped. Okay, and who will harbor the infection? It would be a poultry, it could be your dogs, it could be your cats, it could be your pigs. So what infections they causes? Very important. Uh, yeah, it causes the enterocolitis, which causes the bloody diarrhea, and you need to know it is the most common cause of bloody diarrhea in children's. So whenever the staff will give you a question on the bloody diarrhea, and they won't give you any specific hint of any bacteria, so they're asking you the most common cause in that case, and you will give them the answer Campylobacter jejuni. Remember, whenever they don't give you any specific bacteria to select, you will always answer the Campylobacter jejuni because it is the most common cause of bloody diarrhea in children's. They will also cause this infection, Guillain-Barré syndrome, which you will study in the neurology section. After the infection of this Campylobacter jejuni over, you will get the nerve damage because of the cross reactivity, and you need to know what proteins cross react with the Campylobacter jejuni. These are the GM1 gangliosides. Remember the GM2 gangliosides? Where you studied them? GM2 gangliosides?
Lysosomal storage.
What?
Nematodes.
Say it again. GM2 gangliosides. Anyone?
Lysosomal
Tay-Sachs disease,
storage.
remember? Yeah, Tay-Sachs disease, remember? So that GM2 gangliosides, the Tay-Sachs disease, and GM1 gangliosides, Guillain-Barré syndrome, because of the cross-reactivity of the antibodies. There are some proteins found on the Campylobacter jejuni which cross-reacts with the GM2 gangliosides, and as a result, the antibodies will affect the nerves. And if what you will get is a peripheral neuropathy, you will get the hypotonia. And you need to know that it starts with your foot, and within a week, it will reach to the thigh. And after the second week, it will reach to your lungs. So you need to give the patient ventilator for like 1 month or maybe 2-3 weeks, of course, right? And this disease is of course self-limiting. You don't need to give anything, just a ventilatory support to the patient. So whenever a question stem gives you a case of a diarrhea, and then the patient started having this the weakness of the lower limbs or the loss of sensations of the lower limb, and the sensation will reach to your thighs within a week. So the ascending neuropathy, you can say, okay, ascending symmetric neuropathy you will get in the Guillain-Barré syndrome. And then another complication of the diarrhea, you will get the reactive arthritis. Very important, you will get the reactive arthritis, which you will study in the MSK section when we discussed about this seronegative spondyloarthropathies, and one of them is a reactive arthritis. You will get the joint pains, the conjunctivitis, and the urethritis, the classical triad. Very important. Any doubt? And what you will get in the school examination, you will get the leukocytosis and the erythrocytosis. Remember, it is the most common cause of diarrhea, the bloody diarrhea in the children's. And the hands, dogs, a history of pets or might be a pet lover would be there. And they can ask you what temperature it required to grow. It is 42 degrees centigrade temperature. And micro aerophilic conditions are very important. The Guillain-Barré syndrome is important. Reactive arthritis is important. Okay. Any doubt? Please respond.
No, sir.
Okay. So now the Vibrio cholerae, which causes the watery diarrhea and life-threatening watery diarrhea because it causes the dehydration. So due to the dehydration, you are likely to die. And it has a toxin which is similar to the heat labile toxin of the enterotoxigenic E. coli, which causes the increase in the cyclic AMP to secrete more chlorine, and as a result, the water will follow, and what you will get is the watery diarrhea. So this is a gram-negative curved bacilli. These have this S shape or the comma shape, and they have this flagella, as you can see here in the diagram also. They are oxidase positive, just like any other gram negative curved rod. And they requires the alkaline media to grow. Very important, they requires the alkaline media to grow, and that's why your stomach plays a very protective role from this Vibrio cholerae. And in case if you get the gastroenteritis or you get this proton pump inhibitors, okay, and if you get this pernicious anemia also, and the autoimmune gastroenteritis if you get, then in that case you're likely to have this Vibrio cholerae infection, because you will lose the stomach acidity. Okay, and because of the stomach acidity you require very high dose of these bacteria. Okay, a very large inoculum is required to cause the infection because of the gastric acidity. Okay, it causes a rice watery diarrhea. What is a rice watery diarrhea? It has some kind of a mucoid appearance because they causes the increased secretion from the goblet cells. Okay, so we will have the mucin or the mucus rich stools, mucus and watery stools you will get, and this is the rice watery diarrhea, somewhat whitish type. Okay, and the toxin is very important. How we will get the infection? By the contaminated water. Like in the underdeveloped countries, you will have this contaminated water. So it would be the patient generally gives you a history of traveling to the underdeveloped countries. Okay, very important. The history of traveling would be there, because in United States you're not likely to have this infection. So underdeveloped countries or any history of traveling to the African countries or in any other areas, you will get the Vibrio cholerae, okay, or the raw shellfish. Okay, and it is very important that do not invade your GI mucosa, and as a result you won't get the leukocytosis or the erythrocytosis, right? But you will get the increased release of serotonin. Very important, you will get the increased release of the serotonin. So in the stool examination, what you will get? Water, you will get the mucus, and you will get the serotonin. Okay, water, mucus, and serotonin. These three things are very important. And what is the treatment? They can ask you, it is an oral rehydration solution or the ORS. They can also ask you about certain factors that are present in certain the constituents of the ORS, and the most important ones are the electrolytes like NaCl, the glucose, and of course you will take them with the water. So water, glucose, and sodium chloride is very important, and the potassium ions also. Any doubt in the Vibrio cholerae? How will I identify this bacteria? By the curved shape or the S shape and the flagella, and these are gram negative, oxidase positive. and they require the alkaline media to grow. And the other histories the patient might present you with are the PPI history, the proton pump inhibitors, or might be the autoimmune gastritis, or might be the case of agalor hydra. Okay, very important. Any doubt? Anyone?
No, sir.
Then comes the Helicobacter pylori. How you will identify the organism? This is basically they are just like any other curved rod. They are very curved. They have this flagella. They are gram negative. They are oxidase positive, and I told you already they are urease positive. Okay, and they are also catalase positive. Remember the mnemonic? The cat need places to bite here, something like that. Okay, the catalase positive, oxidase positive, and urease positive. They are triple positive, you can say. Okay, and there's this urea breath test which you use to diagnose the infection. Okay, and yeah, why they require the urease enzyme? Because this urease enzyme basically converts your urea into the ammonia, and thus creating a alkaline environment. Okay, and they most commonly colonize the antrum part of the stomach. Very important, they most commonly colonize the antrum part of the stomach, which is this part. This is a diagram of the stomach. So this is this part of the stomach that they will colonize. Okay, so whenever you do a biopsy for any kind of ulcer in the GI tract, especially for the duodenal ulcers, where you will take the biopsy sample, will ask you this is the antrum part, because it is where your bacteria will likely to be found. Okay, very important, the antrum part, they will form their colonies at, and it causes the gastritis, which is inflammation of your GI tract. So basically they can cause the GI ulcers, the duodenal ulcers, or the stomach ulcers. Initially, they will cause the duodenal ulcers, and if the disease progress, they will cause the stomach ulcers also. Okay, very important. And they can also ask you about which part in the duodenum they will cause the ulcer. It would be the first part of the duodenum. Very important, they will cause the ulcers in the first part of the duodenum. And if the step one mentioned the ulcers in the distal part of the duodenum or maybe the jejunum, it won't be the case of H. pylori infection. It would be your Zolliger-Ellison syndrome. Remember the gastrinoma? It causes the ulcer in the distal part of the duodenum or the jejunum. But in the proximal part of the duodenum, it would be your H. pylori infection, and where you will take the biopsy in the antrum of the stomach. Okay, we will discuss the detail of this disease later in the GI section. Okay, just know these facts for now. Then the treatment, it would be amoxicillin. Okay, the clarithromycin and the proton pump inhibitors. Okay, and you can also take the metronidazole if the patient is having this amoxicillin allergy. Okay, so metronidazole in case of amoxicillin allergy, or you will get these 3 drugs, the triple therapy. Okay, and bismuth sucralfate is basically the agent which forms a protective layer over the ulcers. You can use them in this quadruple therapy. So the triple therapy involving your amoxicillin, proton pump inhibitors, and the clarithromycin, and the quadruple therapy includes your bismuth. Okay, very important. And you can also do the Giemsa staining as well as the silver staining. Very important. The step one most likely to give you the silver staining for the H. pylori, and it will appear as these black bacteria in the yellowish background. So whenever you see this type of slide, the yellowish background and some blackish bacteria, they were most probably giving you a case of the H. pylori infection. Then comes the spirochetes, and I've told you one fact about these spirochetes, that they do not show any gram staining because they are very small to identify. They are very thin to identify, and it includes 3 bacteria, which is the Borrelia, the Leptospira, and the Treponema. They are all having this cork screw shape like appearance. Okay, this cork screw shape appearance very important, and you uses the right staining or the Giemsa staining to identify these organisms. The right staining or the Giemsa staining, very important. And the Treponema can also identify using this dark field microscopy, okay, or the direct fluorescent antibody test. Either the dark field microscopy or the direct fluorescent antibody. They are very specific tests for the spirochetes and this Treponema. Okay. Then let's talk about the this Borrelia burgdorferi, which causes the Lyme's disease. Okay, and you need to know which what animal harbors this organism. These are the exotics, and these ticks are found on the deer. So remember, it is the exotics, not the deer, which causes the infection. Okay, deer do not harbor this bacteria. It is the exotics which are found on the deer that harbor the bacteria. Okay, and these exotics are the same ticks which harbor the Anaplasma species. You will study that later. And the Protozoa babesia, very important. They will ask you, they will give you a case history of the babesiosis, and they will ask you what other organisms these ticks harbor. So you will answer Anaplasma and the Borrelia. So Borrelia, Anaplasma, and babesia, they have this common tick. Okay. Then deer and mouse harbor these exotics, very important. And most probably the patient would be of Connecticut. Very important, the place name, the Connecticut is very important name. Most probably whenever they give you a case of Borrelia or the Babesia, it would be a patient from the Connecticut. Okay. Then the disease, it would be divided into 3 stages: the stage 1, the stage 2, and the stage 3. In the stage 1, you will have this bullseye rash where the tick bite, and you can also remember the locations, because the patient generally gives you a history of some kind of a jungle visit or a camping, or it might be a patient who works in the jungle. Okay, any fighter there. So the areas of your body which are exposed, like your forearms or the ankles, okay, or sometimes the thighs. So these are the locations which will get this kind of a rash. Okay, it has this dark dusky center. Okay, then followed by a pale area, and then again a dark area, a targetoid like rash or the bullseye rash you will get. Okay, along with the flu-like symptoms like fever, chills, headache. So whenever the patient gives you a symptom history, which is fever, chills, headache, and a rash, shortly after some kind of a jungle visit or a camping trip. Okay, so it could be on a case of your Lyme's disease. And if this rash is go unnoticed, then the patient will enter the stage 2, where this bacteria will disseminate to your body and causes the AV block. It is a 3rd degree AV block. Remember, 3rd degree AV block, where your atrias and ventricles just contract independently. Atrias are contracting at their own rate and ventricles are contracting at their own rate. This is a 3rd degree AV block you will get in the Lyme's disease. You will also get the facial nerve palsy, which is the Bell palsy. You will get the drooping of the mouth. You will get the drooping of the eyes. Okay, something like that. And the myalgias and the arthritis. You will get the arthritis involving multiple joints like elbow, like your knee joint, or maybe your hand joints, small fingers. And then comes the stage 3, which is the late dissemination. You will get the encephalopathy. You will get the neuropsychiatric symptoms in this disorder. You will get the joint pain. So remember these 3 stages. In the stage 1, you will get just a fever, chills, and the rash, which appears like this, the bullseye rash. In the stage 2, it will be disseminated. It will go to your heart, causing the AV block. It will go to your brain, causing the Bell's palsy, and it will also affect your muscles or the joints. And then the stage 3, you will get the chronic arthritis and the encephalopathy. And it's a monoarthritis, not a symmetric, but a asymmetric. It will in fact it would involve only one joint, like unilateral elbow joint or unilateral knee joint. Okay, not the bilateral. Okay, so for the treatment, if it is not disseminated, if it is still in the stage 1, you will give the patient doxycycline. And if the systemic infection occur like AV block or the Bell's palsy, you will give the patient ceftriaxone. So ceftriaxone for the systemic infection or the dissemination, and doxycycline if the patient is having this stage 1 disease. And you can also remember one important fact, that for any tick bite, you will always give the patient tetracyclines. For any kind of tick bite, you will give the patient these tetracyclines, which are the doxycycline. Very important. Okay, so any case of heart block, Bell's palsy, and arthritis, you will always think about the Lyme's disease. They will ask you the tick name, which is exotics. They will ask you what other bacteria or protozoas harbor this can be harbored in the exotic. This would be an Anaplasma and a protozoa. You need to remember the location name, Connecticut. It would be easy to identify if you remember the name. Okay. Any doubt regarding this Lyme's disease?
If it's doxycycline, if it's a child, we cannot give doxycycline, or always gonna be a case of adult in the test.
I understand. Please repeat it again.
You say always do give the patient doxycycline.
Yeah.
But what about if it's a child? We cannot give doxycycline, right? So my question is, in the test, is always gonna be an adult, basically.
Basically, most likely they will give you a case of adult, not the children's, because we are not in the step 2, we're in the step 1 only, right? So we do not need to worry about the first line treatments or the second line treatments anymore, right?
Yes.
So
okay.
just leave it for the step 2 only. And for the step 1, you just need to know that the doxycycline is a first line therapy. Okay. If the patient is presenting you with a rash, then you will give the patient doxycycline. If they're presenting you with this AV block and the Bell's palsy, we will give the patient ceftriaxone. Okay. I've never encountered any case of the children, so I really don't know if you give them the doxycycline or not. Okay, but amoxicillin is also an option for these children, I guess. Amoxicillin, okay, you can give to the children, if not a doxycycline. But very important to know that any kind of tick infection, you will always give the patient tetracycline for any tick infection. So it would be easy to remember by this fact. Okay.
Okay, thank you.
Then apart from the Vibrio cholerae, you need to know about this Vibrio vulnificus, and you will get the infection. This is just the strain of the Vibrio, and how you will acquire the infection of this Vibrio vulnificus by the brackish water, which is the marine or the ocean water. Okay, and most probably they will give you a patient, having the disease in the summers. Okay, while doing the summer activity like rafting. Okay, or might be the boating. Okay, and generally it causes the skin infection. It will cause the mild cellulitis if you're an immunocompetent patient. If you do not have any secondary diseases, then what you will get is just the mild cellulitis. Okay, but you're having the liver diseases like hemochromatosis, or might be the hepatitis, or might be the cirrhosis. If that is the case of patient, then he will likely to get this very severe infection. Okay, it will cause the necrotizing fasciitis. And remember, I told you about this necrotizing fasciitis. It will be like cellulitis, but a deep infection. So you will get the shock. So whenever you encounter a case of a patient having the history of cellulitis and plus the shock or the bacteremia, this would be the necrotizing fasciitis. You can get this infection by the Vibrio vulnificus by swimming in the brackish water or the ocean water. Okay, very important. They will ask you what kind of a history contributing to these severe symptoms. So you will give the liver diseases or might be the iron overload, because these bacteria actually feed on the iron of your body. So very important, the iron overload conditions like hemochromatosis. You will get very severe infections like the necrotizing fasciitis. You will get the cellulitis plus the septic shock. Okay, and also hemorrhagic bullas would be formed. Any doubt about this Vibrio vulnificus? Gram-negative bacteria, summer, and ocean water, cellulitis for the healthy patient, and for the diseased patient like liver diseases and hemochromatosis, you will get the necrotizing fasciitis. Okay. Any doubt? Then the leptospira, which is again a spirochete. Okay, it is found in the water which is contaminated with the animal urine. Very important. It is found in the water which is contaminated with the animal urine. So what you will get is a leptospirosis, and it would be a case of a patient who is gone for a summer vacation like Hawaii. Okay, and from there, by swimming in this contaminated water or the ocean water contaminated with the animal urine, you will get the infection. So what would be the infection symptoms? It would be just the flu-like symptoms like your fever, chills, headache. Then you will get the muscle pain, and especially the muscles of the calves you will get. You will get the leg pain. The patient will complain of the leg pain, very important. And you will get the organ damages If they involve your liver, you will get the jaundice. If they involve your eyes, you will get the photophobia with the conjunctival suffusion, which is a reddening of the eye without the inflammation. Okay, there won't be an inflammation in your eye. It's just the a reddish discoloration of the eye. It is the conjunctival suffusion. Okay, erythema without the extubate. Okay, so Hawaii, very important. Generally, they will give you a case of a Hawaii patient. Okay, and it occurs by swimming in the water which is contaminated with the animal urine. They can ask you this fact. Okay, and the symptoms will be just a flu-like symptoms: fever, chills, headache, leg pain, which is the myalgia due to the pain in the calves. You will get the end organ damage involving your liver. You will get the jaundice involving your eyes. You will get the photophobia. Okay, and you will get the reddish discoloration of the eye without any inflammation. Okay, and you will also get the Weil's disease, which is a very severe form of this leptospirosis. You will get the severe end organ damage. You will get the liver dysfunction. You will get the kidney dysfunction. You will get the anemia. You will get the hemorrhage. So whenever they give you a case of a patient who is having a history of traveling, especially to the Hawaii, okay, and now he's having the symptoms like fever, myalgia, headache, chills, and he's having this high LFT count, he's having this high creatinine, he's having this hepatosplenomegaly, he's having this renomegaly, he's having this oligouria, liver dysfunction or the kidney dysfunction or the jaundice. You will always think about the leptospira. They will ask you how he will acquire the infection, and it is by swimming or uh, by getting contact in a water which is contaminated with the animal urine. Very important. Okay, any doubt? Leptospira? Anyone? Anything you want me to repeat? No?
No, sir. You can.
Okay, then comes the syphilis, which is again caused by a spirochete named the Treponema pallidum. Very important, Treponema pallidum. Okay, and you need to know the stages of the syphilis, which is the primary syphilis, the secondary syphilis, the tertiary syphilis, and the congenital syphilis. So for the primary syphilis, they can ask you, how does a person acquire the syphilis? It is by the sexual contact. Okay, it is a sexually transmitted disease. Very important. Okay, and in the primary syphilis, you will get a painless chancre. As you can see like that, this is a very painless ulcer. Very important, painless ulcer. Okay, and yeah, just this. So most of the times this ulcer would go unnoticed because there won't be any symptoms, there won't be any pain, it's just the painless ulcer. Okay, and along with the painless ulcer, you can also get a painless inguinal lymphadenopathy. So whenever a step one gives you a patient who is having this painless ulcer and the painless inguinal lymphadenopathy, both of these things together, it will always be a case of syphilis. And if they give you a case of a patient having this painless ulcer and a very painful inguinal lymphadenopathy, it would be a case of lymphogranuloma varinum. Okay, very important. So you need to know how to differentiate between between these two diseases. In the syphilis, it would be a painless ulcer and a painless inguinal lymphadenopathy. In case of lymphogranuloma varinum, you will get the painless ulcer and the painful inguinal lymphadenopathy. And if you get just the painful inguinal lymphadenopathy, it would be a case of your bubonic plaque, Yersinia pestis. How you will diagnose a disease? The primary infection. This is your dark field microscopy we have already discussed, or the direct fluorescent antibody staining test, or the VDRL test, which is positive in 80% of cases. So even if the question stems gives you a VDRL negative, you won't exclude the disease. Okay, this might be the 20% cases where you get the VDRL negative. So if the patient is having the symptoms of painless ulcer and the painful lymphadenopathy with the VDRL negative, you cannot exclude the disease. Symptoms are positive. That means you are positive with the syphilis. Okay. And it happens due to the skin-to-skin contact during the sexual intercourse. Very important. That's why you get the disease. Then comes a secondary disease. And at that time, the bacteria just disseminate throughout your body. You will get the constitutional symptoms like fever, headache, and weight loss and muscle pain. Just like the flu-like symptoms, you will get the fever, headache, weight loss, and the muscle pain. And along with that, you will have the maculopapular rash throughout the body, involving your palms and soles. Very important, you will get the maculopapular rash involving your palms and the soles. Only 3 diseases have rash on the palms and soles. One of them is the syphilis, second is the rickettsia, and third is the uh, Coxsackie virus. Only 3 diseases have the rash on the palms and soles. One is the syphilis, second is the rickettsia, and third is the Coxsackie virus. Okay, you will get the condyloma lata. Okay, which is a wart-like lesions on the genitals. So all over the body, you will get a maculopapular rash, and where you have this ulcer before, now you will get the wart-like lesions there, just like the human papilloma virus, the warty lesions. Okay, so at the inguinal areas, you will get the warty lesions, the condyloma lata, and all over the body, you will get the maculopapular rash, even involving your palms and the soles. You will also get the patchy hair loss, very important, and you will confirm the disease by the dark field microscopy or the FTA antibody test, which is a fluorescent antibody test. Okay, and after this secondary disease, you will get a latency period where you do not have the symptoms, but the bacteria would still be inside your body. Okay, yani ki you will get a positive serology without any symptoms. And along with this thing, the patient also have this generalized lymphadenopathy, a painless lymphadenopathy, like I told you already, the painless inguinal lymphadenopathy. So the patient with painless ulcer with painless inguinal lymphadenopathy will always be a case of syphilis in the step 1, of course. Then comes the tertiary syphilis, where you get the gumas, which are the granulomas throughout the body. As you can see here in this diagram, these are the granulomas that are found throughout the body of the patient. These are the gumas. You will get the involvement of the arteries that causes the iotitis. Okay, and due to the vasa vasorum destruction, which is the veins that supplies your arteries. Okay, so if the veins that supplies your arteries get damaged, what you will get is a loss of blood supply to the arteries, and so the inflammation of the arteries would be there, iotitis. You'll also get the neurosyphilis that can lead to the tabes dorsalis. You will have the degeneration of the posterior columns of the spinal cord. So you will only get the sensory loss. Okay, you will get the loss of sensations, heat, temperature, heat, pressure, the proprioception, and that's why you will get the positive Romberg test. Whenever you ask the patient to stand keeping the eye closed, he will fall off. And that is a positive Romberg test that you will get if you damage your dorsal columns. Okay, because of the loss of proprioception. You will also get the Argyll-Robertson pupil, which constricts on the accommodation but do not reactive to the light. So if you shine the light in the eyes of this patient, the pupil won't contract. But if you take a pen and bring it closer to the eyes, then during the accommodation, the pupil will constrict. Okay, and yeah, just this, you will get a broad-based ataxia because of loss of proprioception. You are not able to identify anything. Okay, and you can also get this joint involvement, the Charcot joint, and you will get a stroke without a hypertension. Okay, and for the neurosyphilis, because it is involving your brain, so it will infect your CSF. So what you will do is the CSF test or the spinal fluid test. Okay, and then comes the congenital syphilis, and you need to know that the transfer of syphilis through the placenta occurs in very early pregnancy. So you need to treat the mother as soon as possible. Very important. The placental transmission of this syphilis occurs in the first trimester, very early stage of the pregnancy, and that's why you need to treat the mother as soon as possible. So what you will get is the ruggeds, which are these marks, the scars, the linear scars at the angle of the mouth. In the black arrow, as you can see, these are the ruggeds. You will get the snuffling of the nose. You will get this continuous nasal discharge. So the patient will keep on sniffling. Okay, you will get this saddle nose, which is a nose deformity. Okay, you will got the notched teeth, very important, the Hutchinson teeth. Okay, and yeah, then you will get the involvement of the cranial nerve 8, which is involved in your hearing. So you will get the hearing loss, the deafness. Okay, you will also study that syphilis later in the torch infection. Okay, we will discuss this later again. So just know the symptoms: the linear scars over the angle of the mouth, the continuous nasal discharge that lead to the sniffling, the saddle nose deformity, and the Hutchinson teeth. Okay, and Hutchinson teeth would be like that. Let me draw this for you. These notched teeth, something like that. These are the Hutchinson teeth. As you can also see here, these teeth, these are notched teeth. These are the Hutchinson teeth. Okay. And step 1 will ask you what you will found in the biopsy of the patient at any stage of the syphilis. When you do the histopathological examination of the patient or the biopsy of the organ of the patient, what you will get at any stage of the disease, you will get the inflammation of the arteries. Very important. You will get the inflammation of the arteries. So endarteritis you will get. Okay, very important thing. You will get the proliferative endarteritis. This was my exam question also. So you guys can remember this fact. Whenever you do a histopathological examination at any stage of the syphilis, what you will get is the endarteritis, which is the inflammation of your small blood vessels. Okay, and every symptom that you notice here, it is due to the result of the fact that they are that the blood vessels are keep on damaging, right? So we lost the blood supply to the organs or to the areas where the syphilis affects, and that's why we're having all of these symptoms because of loss of blood supply. Okay, because of the ischemia that is result from the endarteritis. Very important. These are the warts that you see in the syphilis, the condyloma lata. These are the maculopapular rash, and as you can see, these rashes are involving your palms and the soles. Any doubt in the syphilis? Any doubt?
No, sir, we can.
Okay, and you also need to know the treatment of the syphilis, which is the penicillin G or penicillin V. Anyone could do the penicillin G or penicillin V, very important. Okay. Then comes the false positive VDRLs. That means not just in the case of syphilis, but in other diseases also you will get the VDRL positive, and these are the false VDRL positive. Okay, and you need to know what the VDRL test is. It basically detects the antibody that reacts with the beef cardiolipin. It is a protein found in the beef. So the beef cardiolipin, the antibodies that forms against the syphilis bacteria, they react with this beef cardiolipin, and that's how you diagnose this disease by the VDRL. But you will also get the false positive VDRL in case of pregnancy, in case of the viral infections like Epstein-Barr virus or the hepatitis virus. You should need to know the drug names that are the chlorpromazine and the procainamide, very important. You will also get this false positive VDRL in case of rheumatic fever and the lupus and leprosy. Okay, lupus and the leprosy. Okay, very important. In the lupus, you will get this antiphospholipid antibody syndrome. So positive in antiphospholipid antibody syndrome, in the leprosy, in rheumatic fever, in drugs, in the viral infection, in the pregnancy. You can remember by the mnemonic false positive, the P of VDRL. So false positive VDRL is a mnemonic you can use. And you should know what are the non-specific tests for the syphilis and what are the specific tests for the syphilis. So the non-specific test includes a VDRL test. Like I told you, it not just in case of syphilis, but other diseases can also have the positive VDRL. So it is a non-specific test for the syphilis. The rapid plasma reagent test (RPR) is also non-specific, but the treponema pallidum antibody is very specific for the treponemal antibody, and the FTA antibody test is also very specific. For the direct microscopy testing, you have this dark field microscopy and the polymerase chain reaction test, which are very specific for the syphilis also. Then you need to know about the Jarris-Hexheimer reactions, which occurs when you give the patient treatment for the syphilis. So what happens when you give the patient penicillins? It leads to the destruction of the cells, and as a result, the destruction of the cells or the bacteria, the treponema, will lead to the leak out of the contents of the syphilis, and as a result, the inflammation will or the immune reactions happen against these uh, against these contents of the bacteria, and what you will get is the flu-like symptoms like fever, chills, muscle pains. And why this happened? Because of the killed bacteria that releasing the toxins. Like I told you, endotoxins are released whenever you kill the gram-negative bacteria. So these endotoxin and other cellular components of the bacteria, when they release out of the cell, they will lead to the inflammation. And because of this inflammation, you will get the fever, chills, headache, myalgia. So step one will ask you, it would be a case of a syphilis patient. He was receiving the treatment and now he's presenting to your emergency department with this fever, headache, muscle pain and chills. So they will ask you what are the cause of these symptoms, and it is due to the toxins which are releasing by the dead cells. Okay, due to the cellular destructions or by the this penicillin. So it is not a hypersensitivity reaction, it's just due to the destruction of the bacteria. It's very important. Then comes the Gardnerella vaginalis. And one of the most important fact that you need to know that it is a pleomorphic gram variable rod. You cannot differentiate it into the gram positive or gram negative. These are the gram variable rods. Okay. And they also colonizes your vagina, very important. Okay. And whenever they cause the vaginosis, please remember it is vaginosis, not the vaginitis. So there won't be any inflammation of the vagina. Okay. They're just the overgrowth of these bacteria, and what they will cause is the grayish discharge from the vagina. So whenever you encounter a patient having a grayish discharge or the watery discharge from the vagina without any reddish or without any sign of inflammation, what you will suspect is the vaginosis. And you will get a fishy odor of this discharge. Okay, you will get the fishy odor, and it is related to the sexual activity, but it is not transmitted sexually. It is not a STD. It can never be transmitted sexually, but it is related to the sexual activity. Okay. And bacterial vaginosis, like I told you, it is due to the overgrowth of the certain anaerobic bacteria in the vagina due to the loss of lactobacilli. So what you will get is the clue cells. Clue cells are nothing but just the epithelial cell of the vagina that are lined by the bacteria. As you can see here, this is the epithelial cell and it is lined by the bacteria, the Gardnerella. These are the clue cells that you will see in the Gardnerella vaginosis. And there is one more test, which is the amine Whiff test. What happens when you mix the KOH, the potassium hydroxide, in the discharge? Okay, you will get the enhanced fishy odor. Okay, so whenever you add the potassium hydroxide in the discharge, you will get the enhanced fishy odor, and this is the amine Whiff test. Okay, you will see the clue cells in the wet mount. Okay, and the treatment includes some metronidazole or the clindamycin. Either of the drugs could be used. Most important one is the metronidazole. If the metronidazole is not important, you will give the patient clindamycin drug. Anyone remember the function of the clindamycin? The mechanism of action of the clindamycin? Anyone? The function of clindamycin, how it acts? The chloramphenicol and the macrolides, remember? It can work like these two drugs.
The ribosomes?
Yeah?
Does it act on the ribosomes by inhibiting the
Exactly.
50S?
No, they yeah, exactly. You're thinking same. They basically can act either on the 50S subunit or on the 30S subunit also. But most important one is the 50S subunit. They basically inhibit the peptide linkage transmission. Remember the enzyme
Yes.
ribozyme or the peptide transferase? Remember what happens? They transfer the peptide bond from one tRNA to the other tRNA, right? They can inhibit this transfer of the peptide bond. Okay. And second thing, they can inhibit the translocation of the ribosomes, just like your macrolide antibiotics. Okay. So it can work like both, either the chloramphenicol or the macrolidic antibiotics. So remember the function of the clindamycin, very important. They can ask you this. Okay. So any doubt on this Gardnerella vaginalis? It is not the inflammation of the vagina, but just the overgrowth of certain bacteria. So you won't get any sign of inflammation. There won't be any pain. There won't be any redness. Okay. There won't be any swelling or anything like that. Just a fishy odor and a grayish watery discharge from the vagina. Okay. and it is not a STD. Very important. It is related to a sexual activity, but not the STD. So you just need to treat the female patient, not his, not her partner. Okay, just the patient, not the partner. Okay, any doubt?
No, it's good.
Okay, then comes the chlamydia. And you need to know that chlamydia only exists in the intracellular, only the intracellularly, because it is an obligate intracellular organism. Okay, they require the host ATP for their survival. Okay, because they cannot make their own ATP. And you need to know, apart from the chlamydia, rickettsia is also intracellular, obligate intracellular, because just like the chlamydia, they depend upon the host ATP for their survival. Okay, and they exist in two forms. The one form is is the alimentary body, which helps them in the entering the cell. So alimentary body for the entering cells, and then when they enters the cell, this alimentary body transforms into the reticulate body. Okay, and this reticulate body helps the bacteria in replication. Okay, so alimentary bodies for the entry inside the cell, and reticular bodies for the replication inside the cell. So whenever you look this chlamydia in the microscope, what you will see is the intracellular bacteria, right? And what you will see are the reticulate bodies, not the alimentary bodies, but the reticulate bodies. Okay, and during the exit from the cell, they will reorganize into the alimentary bodies again. Okay, then you need to know the species or the strains of the chlamydia. One is the chlamydia trachomatis. Okay, second is the chlamydia pneumonia. Okay, third is the chlamydia psittaci. As you can see, three strains. One is the chlamydia trachomatis species. Sorry, one is the chlamydia trachomatis. Second is the chlamydia pneumonia, and the chlamydia pneumophila. Third, and the fourth one is the chlamydia psittaci. Okay, four: trachomatis, pneumonia, pneumophila, and the psittaci. Four are there. Three, I think. I'm sorry, I'm keep on confusing. It's three, not four. Okay, three: trachomatis, pneumonia, and psittaci. Okay, and you need to know about the different strains of the chlamydia trachomatis, which are listed in the next page. The serotypes of the chlamydia trachomatis. First are the three serotypes, the type A, B, and C, and they causes the African disease, the chronic conjunctivitis, which can lead to the blindness. So remember the A, B, C strains, which are in the African strains, as you can remember by the mnemonic ABC, they're found in the Africa. They can cause the blindness by causing the chronic infection of the eye. The chronic follicular conjunctivitis they can cause, that can lead to the blindness. So only in the African group. So it would be a patient who has a history of traveling to the African regions, or might be a history of a patient who is an immigrant from the Africa. Okay, so you can suspect the ABC serotypes. Then comes the serotypes from D to K, and they are involved in the pelvic inflammatory diseases like urethritis. Okay, you will also get this involvement of the uterus and the fallopian tube and the ovary also in the pelvic inflammatory diseases. Okay, and because of the pelvic inflammatory disease, there would be inflammation of your fallopian tube and the uterus. So what you will get ultimately is the scarring, and the fibrosis, healing by the scarring or the fibrosis. So there are very high chances of the ectopic pregnancy in these patients, as well as the infertility. So either you get the infertility or you get the ectopic pregnancy if you get this chlamydia trachomatis infection. Okay, and they also causes a neonatal pneumonia, which causes the stapho cough. In this cough, the patient will cough and then inspire, then cough, then inspire, then cough, then inspire. Okay, so one cough, one inspire, one cough, one inspire, one cough, one inspire. Okay, and you will also get the neonatal conjunctivitis, which happens during the delivery of the baby through the infected vaginal canal. Okay, so it happens during the delivery of the baby during the passes through the infected vaginal canal, just like your gonorrhea. Okay, you can get this neonatal conjunctivitis in case of chlamydia also. Then comes the L1, L2, and L3 stains, which are responsible for the lymphogranuloma varinum. Remember, I told you already about this disease. You will get the painless ulcers and the painful inguinal lymphadenopathy. And the treatment, because it is also transmitted through the ticks, it would be a doxycycline. Okay, So doxycycline is the treatment that you will give, and the symptoms would be your painless ulcers with painful inguinal lymphadenopathy. And if you get the painless ulcer and painless inguinal lymphadenopathy, it would be your syphilis. So please know how to differentiate between these two bacteria. Okay. So either you can be infected with with one of these serotypes, or either these D2K strains, or might be the L1, L2, L3 strains. Okay. So depending on what infection they are causing, you can identify the strains also. Then comes the Chlamydia pneumoniae, which causes the pneumonia. And just like any other pneumonia, it would be the pneumonia, of course. You will get the cough, you will get the lungs involvement, you will get the bilateral patchy involvement of the lungs. And the cough would be the dry cough, not the productive cough. You won't get the sputum production in this case. Okay, and bilateral lung involvement would be there. Okay, and it is known as the atypical pneumonia. Yeah, someone is saying something.
In microtracheomata serotypes, there is written eosinophilia. Why there is eosinophilia in intracellular organism infection?
Where?
Types DK.
Yeah.
In type DK, there is a eosinophilia written besides.
Yeah, eosinophilia. Yeah.
Why there is eosinophilia in this infection?
I really don't know why it is written, because I never encountered any fact or any case about this eosinophilia. I think it's just a fact you should remember about it. Okay. I don't know the reason.
Okay.
I never encountered any question on it. Okay, so that's why I don't know. But you can Google it for sure, and you can type in the comment box.
Thank you.
Okay, and similar to the Chlamydia pneumonia, there is a Chlamydia piscitaci, the Chlamydophila piscitaci, okay, which has a reservoir of the parrots. So it is a very the species of the parrot, which is known as a piscitaci species. This Chlamydia found in this piscitaci species, and you will get the infection, the pneumonia from the Chlamydia piscitaci by getting into contact with the parrots. Very important. You will get the infection by getting contact with the parrots. Very important. Okay. And yeah, that's it. That's about these three species of the Chlamydia trachomatis, the pneumonia, and the Chlamydophila piscitaci. Okay. Very important. And how you will diagnose the disease? Well, one is by the PCR, of course. Second is a nucleic acid amplification test, the NAT test. Remember where we have used this test before? The bacteria.
Neisseria gonorrhea.
Exactly. And I've told you that gonorrhea and chlamydia generally causes the co-infection. So during the treatment of either the chlamydia or the gonorrhea, you need to give the treatment for both. You need to give the patient azithromycin, doxycycline, as well as the ceftriaxone for a possible concomitant gonorrhea. So if you encounter a question explaining a patient who is having this STD, the PID or the urethritis, and now he has given either this azithromycin or the ceftriaxone, but not the both. And now after 1 or 2 years, he is presenting to your emergency department with a history of infertility or the ectopic pregnancy. So they will ask you what is causing the infertility. So you will give the answer, the incomplete treatment or the insufficient treatment. Okay, because you need to give patient both azithromycin as well as ceftriaxone. If you fail to give either one of these two drugs, what you will get is a chronic complication of the STD or the PID. And one of them is the infertility and other one is the ectopic pregnancy. Okay. And when you do the Giemsa staining and you look upon the microscope, look in the microscope, what you will see are the reticulate bodies, because they are found inside the cells. Okay, very important. And like I told you, they have, yeah.
Is there a difference between this nucleic acid amplification test and a PCR? Are these two different?
No. Like you use the PCR for the NAT, actually. You use the PCR for the NAT. So difference would be there, yeah, for sure. No, not same, but they're similar to each other. Okay, in both PCR and the nucleic acid amplification test, you use the PCR. Okay, but they have some difference also. Okay. And yeah, one more thing I want to tell you, like I already told you this, they have this special type of cell wall. They do not have the N-acetyl muramic acid, the NAM, in their cell wall, and that's why cross-linking do not takes place. And like I told you, the beta-lactam antibiotics or the penicillins, they basically act on the muramic acids to inhibit the cross-linking. And in these bacteria, cross-linking won't take place, and that's why they have this intrinsic resistance against the penicillins or the beta-lactam drugs. Very important, okay? So that's it about the chlamydia. Any doubt?
What is atypical pneumonia?
In the normal pneumonia, what you will get is a productive cough. Okay, you will get the cough with lots and lots of sputum, the rusty sputum. Remember, and you will get the unilateral lung involvement, the consolidation. Okay, but in this atypical pneumonia, what you will get is the dry cough only. Okay, you will get the cough without the sputum. Okay, and the symptoms are very milder than the pneumonia, than the normal pneumonia, than the typical pneumonia. Okay, and you will get a bilateral patchy lung involvement, not the whole locale consolidation, and that's why it is known as atypical pneumonia, because you're having the atypical symptoms. That's why the term atypical pneumonia. Okay.
Okay, thank you.
Only 3-4 bacteria causes this atypical pneumonia. I will list down the names later in the pages. The chlamydia, and this mycoplasma pneumoniae, they also cause the atypical pneumonia. And this Legionella, they also causes the atypical pneumonia because you get the dry cough in the Legionella infection. So they also cause the atypical pneumonia. Okay. Then comes the zoonotic bacteria, which are the bacteria that causes infection from the animals. So you will acquire the infection of these bacteria from the animals. First is Anaplasma, like I told you, exotics harbor this infection. Okay, then comes the Bartonella, which causes the cat scratch disease. Very important, you will acquire this bacteria from a cat bite or a cat scratch, and that's why the name cat scratch disease. So what you will get is first of all, the symptoms will be the rash or the scratch mark that you will get on the hand. And when this bacteria enters the body, it will go to your lymphatics and causes a lymphadenopathy. So what you will get is a scratch mark or a bite of the cat, and then the regional lymphadenopathy. And in case of hand, remember what lymph nodes would drain the lymph from the hands, from the arms? I told you in the immunology section. Yeah, axillary lymph nodes. So what you will get the lymphadenopathy of the axillary lymph nodes. So we will get the painful swellings in the armpits. Okay. So in the cat scratch disease, what you will get are the scratch marks on the arm, and you will get the regional lymphadenopathy, which is in case of hand, it would be the axillary lymphadenopathy. Okay, so the patient would be complain of very painful swellings in the armpits, in the axilla. Okay. And one more thing that it can cause, it is a bacillary angiomatosis. In case of AIDS or any immunocompromised patient, this bacillary angiomatosis is like a tumor of the blood vessels. Okay. And so what you will see are the painless bumps all over your body. Okay. And when you try to squeeze these bumps or try to cut these bumps, you will get the lots and lots of bloods, because they are actually the tumor of your blood vessels. The bacillary angiomatosis, the tumor of your blood vessels. Okay. And yeah, that's it. And during the biopsy of these lesions, what you will see is the bacteria and the neutrophils. Okay, bacteria and the neutrophils. So these are the bacillary angiomatosis. There's a virus that can cause the similar symptoms. Anyone remember the herpes virus name? Remember the name of the virus? What? HHV?
Human herpes virus 8.
Yeah, HHV8. Yeah, exactly. HHV8. Okay, remember these things. And how you can differentiate between the two. In case of HHV8, which causes the Kaposi sarcoma, okay, you will get the lymphocytic infiltration. Okay, but in case of Bacillary angiomatosis, you will get the neutrophilic infiltration. So bacillary angiomatosis, neutrophilic infiltration, but in case of Kaposi sarcoma, you will get the neutrophil infiltrations. But both of these diseases will present as same, okay? Because it infects the endothelial cell and is a neoplasm of the endothelial cells. Then comes the Borrelia, the Lyme's disease. We already discussed this, ixotics. Okay, then the Borrelia recurrentis, it causes a relapsing fever. Okay, you will get the fever, then some time of relapse, and you will again get the fever, then relapse, then fever, then relapse. Okay, so relapsing reemerging type of fever you will get in the Borrelia recurrentis, and you will acquire this infection from the louse. Okay, I've never encountered any question on this. Then comes a brucella. Like I told you, will get this by the unpasteurized dairy products, and you will get a brucellosis, which causes a very continuous fever around 104 degrees centigrade. 104 degrees Fahrenheit. Okay, you will get the flu-like symptoms also. So flu-like symptoms with fever and some history related to the milks or a patient who is working in the milk factory or in the meat factory, he will likely to get a brucellosis. Okay. Then comes the Campylobacter. Like I told you, the most common cause of bloody diarrhea in the children is the Campylobacter. You will acquire this infection from the pets, like dogs, cats, or from the chickens and hens and eggs. Okay. Then the Chlamydophila pisittaci. It causes the pisittaciosis, which is the atypical type of pneumonia that you acquire from the parrots, especially species of the parrots. Okay. The Chlamydia pisittaci. Okay. Then comes the Coxiella brutonii. You will study that later in the next page. It causes a Q fever. It is a fever that affects your, it causes the pneumonia along with the liver involvement. So whenever you encounter a case of a patient having this lung involvement as well as a liver involvement, it's always going to be a case of your Coxiella. Okay, then comes the Ehrlichia, which causes the ehrlichiosis. You will study that later in the next page. Okay, and then comes the Francisella, which causes a rabbit fever, and it occurs, by the rabbits. So it would be a patient who is hunting the rabbit, or might be a patient, who has a history of coming into contact with the rabbit either as a pet. Okay, he will likely to get the tularemia or the rabbit fever. Okay, just like the brucellosis, it causes a very high grade of fever only and some flu-like symptoms. Then the Leptospira, and like I told you, you will get the infection by coming into contact with the animal urine during the water activities in the summers. Okay, and the patient might give you a history of the Hawaii. Okay, the history of traveling to the Hawaii. Then comes the Mycobacterium larvae, leprosy. You will acquire this infection from the armadillos in the United States. And plus, you can also acquire this infection by coming into contact with an infected human. Okay, so if you touch the patient with the leprosy, you will get the leprosy. Then comes the Pasteurella multocida. So it causes the cellulitis and the osteomyelitis, and you need to know that it occurs. You get the infection by coming into contact with the animal bite. Okay, so dogs bites especially, because you need to know that this bacteria actually resides in the saliva of the dog. Okay, so if you get a dog bite, you can get the Pasteurella, and of course at the site of this bite you will get the cellulitis. And if the bacteria enters your bloodstream, it can reach to the bones and can cause the osteomyelitis. So for the cats, Bartonella, and for the dogs, it is Pasteurella, and for the rabbits, it is Francisella. So know the history of the patient. If it is rabbit, it is Francisella. If it is dog, it is Pasteurella. If it is cat, it is Bartonella. Then comes the Rickettsia prowazekii, which causes the endemic typhus. You will study that later. And the Rickettsia rickettsii, which you acquire the infection from the dog ticks. Okay, Rocky Mountain spotted fever. You will study that later in the next page again. The Rickettsia typhi, causing the endemic type of typhus. You will study that later again the next page. Then comes the Salmonella species. And like I told you, you will acquire the infection from the chickens, hens, eggs, reptiles. Remember snakes or the turtles. Okay, so you'll get a diarrhea, which is most commonly bloody type. And remember a fact about sickle cell anemia, these Salmonella species are most common cause of osteomyelitis in case of sickle cell anemic patient. Then comes a Yersinia pestis. I have described it already. You will get the bubonic plague, which is a painful inguinal lymphadenopathy, and how you will get the infection by coming into contact with the rodents or the rats. Okay, flea bite from the rat. And the treatment of every of this disease is the doxycycline. Like I told you, every tick disorder you will treat with the doxycycline. So for every disease that is listed here, you will give the patient doxycycline. Okay, very important.
Excuse me.
Someone is asking.
Is it S.
Yeah.
typhi or yeah, I'm asking, is it specified that it's whether it's S. typhi or S. paratyphi that causes osteomyelitis in sickle cell patients?
Please repeat it again. I didn't understand.
I'm asking whether it is specified that it's the S. typhi or S. paratyphi that causes osteomyelitis in sickle cell patients.
Yeah. It is species except the typhoid.
Except
The
typhi. So
salmonella.
it's
Yeah, exactly.
Okay.
These are the species
Not
except the typhoid, which are causing the sickle cell anemia or osteomyelitis. Okay. And generally, if they do not give you a history of osteomyelitis, then the most common bacteria that causes osteomyelitis is your Staphylococcus aureus. And if they give you a history of sickle cell anemia, then you will choose the Salmonella.
So what about the lymphadenopathy and ulcer in case of plague?
In case of plague, you will get the painful inguinal lymphadenopathy, which is a bubonic plague. Like I told you, buboes are basically your painful inguinal lymphadenopathy. These are the buboes. You will also get the buboes in the lymphogranuloma verinum, like I told you, in the L1, L2, L3 species of the chlamydia in the upper page, as you can see here. The L1, L2, L3 species, you will get the painful inguinal lymphadenopathy, which are the buboes itself, along with the painless ulcer, right? But in case of Yersinia pestis, you will get just the buboes, no ulcers, okay? That's how you can differentiate between the two.
Okay.
So you have written, besides Q fever, you have written endometritis. So Coxiella also causes endometritis.
Where?
Besides Coxiella burnetii, Q fever, you have written with red.
Yeah, it is a endocarditis. It is a cause of the endocarditis. You will study later in the cardio section, the native wall endocarditis, or the culture negative endocarditis. It is a caused by the Coxiella, the culture negative endocarditis. So whenever you encounter a patient with a history of endocarditis and you take some type of blood culture and you won't get any bacteria in them, so they are most probably caused by the Coxiella burnetii. Okay, and I will explain that later again. So culture negative, yeah.
In Yersinia pestis, you have written below Yersinia pestis aminoglycosides.
Yeah, aminoglycosides. You can also give them you can either give the doxycycline to the patient or the aminoglycosides. Both are okay.
Which is the drug of choice?
In case of Yersinia, I'm really not sure, because both drugs are listed and they haven't mentioned what is the drug of choice. So step 1 will not ask you this, I guess.
Okay. Thank you.
As you can see here in this point also about the Q fever, the culture negative endocarditis. So you will get the endocarditis, but when you draw for the blood cultures, there won't be any bacteria, there won't be any culture of the bacteria, and that's how you know this must be a case of your Q fever. Okay. Then comes the rickettsia, the vector-borne diseases. First is the rickettsia, rickettsii, the Rocky Mountain spotted fever. Okay, as the name suggests, you will get this by going for the mountain climbing or might be the camping. Okay, and you get this infection by coming into contact with the dog's tick. The vector is a tick which resides on the dog, very important, and it is an obligate intercellular bacteria, just like Chlamydia, because it requires the host ATP for their survival. Okay. And you need to know, okay, because the ticks only bite at the places which are exposed to the environment, like your forearms, or might be the thighs, or might be the ankles, you know. So the most commonly the rash starts at the wrist or at the ankles, because this is the most common site where the ticks bite first. Okay, so the rash starts at the wrist and the ankles, and they progress upward, involving your involving your forearm, then the arm, and finally your central body, which is the abdomen and the chest part. Okay, and please note the fact they also involve your palms and the soles. Very important. They can even involve your palms and the soles. And like I told you, only 3 organisms you need to remember that causes the rash over the palms and the soles. One of them is the rickettsia. Second is the Borrelia. The Treponema. And third one is the Coxsackie virus. Okay, so syphilis, rickettsia, and Coxsackie virus. These are the 3 organisms which causes the rash on palms and soles. So the rash starts at the wrist and the ankles, goes to your forearms and the arms, and finally involving your trunk part. Okay, and you need to know that the bacteria actually affects or attack your vascular endothelium. Okay, so first you will get the systemic signs and symptoms for like fever, headache, muscle pains, fatigue, weight loss, and then you will have the rash. And you need to know that the rash will begin at the ankles and the wrist, and then go the centrally. Okay, and the rash initially are the maculopapular rash, which are the blanching, and then they become the petechial type rash. So initially they are the maculopapular rash, and then the rash became the petechial type of rash. Okay, reddish spots that you will see all over the body. Why? Because they're affecting your endothelium, that leads to the leakage of blood. Okay, and that's why you will get the petechial rash later. Okay, and that begins at the extremities, goes to the central part of the body. You will get the flu-like symptoms as well as the headache. Very important, you will get the headache and fever. So you can think like the meningitis, because meningitis will also show the symptoms of fever and the headache. But when you draw the cultures for the CSF, what you will get is the negative CSF culture. Okay, and you won't have any neck rigidity. Very important. Whenever you encounter a case like the meningitis, and and he's not having the neck rigidity, and if you draw for the CSF cultures, the cultures would be negative, you can think about the rickettsia infection. Okay, even the emboss have mentioned that part. Okay, they present just like the meningitis symptoms, but they have this negative culture for the CSF, and they do not have any neck rigidity. That's how you can differentiate them from other meningitis. Okay, and yeah, that's it. That's about the rickettsii. Then comes the typhus. Okay, and you will get some necrotic rash over the skin due to this typhus. Okay, and it could be caused by the Rickettsia typhi or the Rickettsia kawasaki. Okay, and the patient generally gives you a history of dirty clothes. Okay, very important. They will give you a history of dirty clothes. So it could be a military recruits, or could be a patient who is in the jail. Okay, because they live very dirtily. So most important thing. And the rash start in the central location and then go to the periphery. Okay, while the opposite in case of rickettsia, the rash starts on the periphery, then goes to the centrally. In case of rickettsia kawasaki, it will start from the central part and then goes to the periphery, and they do not involve the palms and the soles. And the patient will give you a history of dirty clothes. It could be a military patient, it could be a patient living in the jail. Okay, and the kind of a blackish type of necrotic type rash. This is a typhus. Okay, and then comes the other rashes. The first one is the ehrlichiosis. Okay, the only thing that you need to remember about the ehrlichiosis is that they have a morula and the monocytes. Okay, mulberry-like inclusions, as you can see, because I told you they are the intracellular organisms. Okay, they all are the intracellular organisms. So basically, you will see these mulberry-like inclusions within the monocytes in case of ehrlichiosis. So if a question is times mentioned some kind of inclusion bodies in the monocytes, it must be a case of your ehrlichiosis. You will get the flu-like symptoms, just like fever, chills. You will get the rash, the maculopapular rash. In the labs, you will have this high LFT count, the high ALT, high AST, you will have the thrombocytopenia and you will also have the lymphopenia. In both of the disease, you will have the thrombocytopenia, lymphopenia, you will have the rash, you will have the flu-like symptoms, you will have the liver involvement, okay? But in case of ehrlichiosis, you will get the inclusion bodies in the monocytes, and in case of anaplasmosis, you will get the inclusion bodies in the granulocytes. Very important, okay? And again, you need to remember the tick name, which is the exotics, the same tick that harbors the Borrelia and the Babesia. Then comes the Q fever, and it is caused by the Coxiella burnetii, okay? And you need to know that it is also a spore-forming organism other than your Clostridium and the Bacillus. This Coxiella is also a spore-forming organism, okay? And the patient generally gives you a history of any farm worker. It must be a patient who is a farm worker. Either they handle the dung of the cattle, or it might be a patient who is involved in the delivery from the cattle. Okay, the cattle delivery, because this bacteria is found in very high concentration in the cattle placenta. Okay, it could be a farm worker delivering the baby from the cattle, or it could be a patient who is involved in the dung of the cattle. Okay, and yeah, so what symptoms you will get? You will get the pneumonia. Okay, atypical type pneumonia you will get a dry cough, you will get the shortness of the breath, you will get the involvement of both of the lungs that you can see in the X-ray, the patchy consolidations in both of the lungs, and plus you will get the liver involvement, the hepatitis, you will get the hepatomegaly, you will get the high ALT, AST count, okay, high LFTs. So whenever you encounter a patient having the pneumonia and the liver involvement, you will always think about the Q fever. Other than these two diseases, they can also cause the endocarditis and the culture negative endocarditis, like I already mentioned this name. Okay, when you draw the blood cultures for the organism, you won't find any organism, and that's how you know it must be a case of your Q fever. If it is not autoimmune, because you can also get the autoimmune endocarditis. Okay, so please be aware of these facts. History is very important in such cases. Okay, if you're getting a history of a cattle exposure and now you're having the endocarditis, it could be a case of your Q fever. Okay. Okay, that's it. That's about the Q fever. Okay, you can get the cattle history in case of salmonella, but remember the cattle in case of salmonella, it causes the diarrhea. But if the patient with a history of cattle exposure coming into your department with this pneumonia and hepatitis, you will always suspect the Q fever. Any doubt? Any doubt?
No, sir.
Anyone?
I think we're clear.
Okay, this question seems very difficult to understand, but they will ask you very simple questions from them. Okay, so don't need to worry. They will ask you very simple questions from this page, very easy ones. Then comes the Mycoplasma pneumonia. Okay, and just like the chlamydia, Coxiella, and coccivirus, and Legionella, and other infections, that causes the atypical type of pneumonia. Okay, and you have this dry cough and the patchy involvements of the lungs. Okay, and bilateral diffuse involvements would be there. Okay, and non-productive cough or the dry cough. Okay, and it is known as a walking pneumonia because the patient has very milder symptoms. Okay, very milder symptoms, and that's why they can go anywhere, they can walk, they can live very freely without noticing any symptoms. Okay, just very mild symptoms over there, and that's why it is known as a walking pneumonia. Okay, and you need to know the most important age groups are the patients which are less than 30 years old, and generally they will give you a history of any college student, or might be a student living in the dorm, or might be a military recruits, because they live in very close contacts. Okay, so generally outbreaks can happen there in the prisons, in the colleges, in the military recruits, because it transmits through the droplets, and these age groups and these groups are basically living in very close contacts, and that's why you will get the outbreaks there. Okay, and you need to know that the X-ray actually looks very worse than the patient's symptoms. The patient present with very milder symptoms like fever and some dry cough and milder shortness of the breath. But when you look at the X-ray, what you will see is very very diffuse involvement of the lungs, patchy consolidations and everything. So the X-ray looks actually very worse than the patient's actually symptoms. It is very important to know. Okay, you will get the bilateral scattered infiltrates in the lungs. And they will also get a very high titer of the cold agglutinins, which are the IgM. Okay, and actually these IgM antibodies formed against the Mycoplasma pneumoniae, and there is an antigen known as the I antigen, which is found on the Mycoplasma pneumoniae. Okay, and what happens if this antigen is also found on the RBC? Okay, so sometimes what happens is this antigen cross reacts with the RBC. So during the infection with the Mycoplasma, you will also get the anemia because of the cold agglutination. Okay, and once the disease is over, once the inflammation against this bacteria is over, you will get the normalization of the RBC count. Okay, so that's it. And how you will diagnose this cold agglutination? You will draw the patient blood, and it will and you will keep that into very low temperature. Okay, like any cold water, or might be in the ice packs. So what you will see is the turbidity in the blood. Okay, and that's how you know that this must be having a cold agglutination, because this agglutination happens in very cold temperatures only. Okay, so we'll take up the patient blood, and you will also mix the anticoagulant in it to make sure that this coagulation is not happening because of the patient coagulation factors. Okay, so you will take up the blood, you will mix it with the anticoagulants like ethylene dimetetracetic acid, EDTA, and you will place that tube into the ice packs. And what you will see is the turbidity and the clumping. And if that occurs, that means the patient is having a cold agglutinations, and one of the cause is the Mycoplasma pneumoniae. Okay, and you will give the patient, and because the Mycoplasma pneumoniae do not have any cell wall, so you cannot give the patient penicillins, right? So what you need to give some alternative drugs like macrolides or the doxycyclines or the fluoroquinolones. Okay, because penicillins are ineffective because it has no cell wall. Very important. And like I told you earlier, they require the cholesterol for their growth. And so you grow them in the E18 agar, and E18 agar is rich in the cholesterol. Okay, very important. You will also get a Stevens-Johnson syndrome in case of Mycoplasma pneumoniae infection, where you get this rash over the skin, and the skin will just sludge off from your body. Stevens-Johnson syndrome. And you will also get the erythema multiforme, in which you will get some targetoid like rash over your skins. Okay, opposite to that of bull's eye rash, like I told you already. In the targetoid like rash, you will have this pale center. Okay, and this pale center surrounded by the dark area, and then again a pale area, and then again a reddish dark area. This is erythema multiforme. Let me draw this for you. So this is your area. The central area is very pale, followed by a dark area. Then again, there is a light pale region. Then again, a dark area. This is a targetoid-like rash. But in case of bullseye rash, what you will have is a dark dusky centers. The center is this much dark, followed by a light area, and then a dark area again. Okay, then a dark area. This is your bullseye rash, and this is your targetoid rash, which you see in the erythema multiforme. Okay, here. So just 4 facts that you need to remember about the Mycoplasma pneumoniae. It is an atypical type of bacteria. It do not have any salt walls. It's a cell membrane which require the cholesterol for the growth, and that's why you grow them in the E18 agar. So you have this walking pneumonia, which is an atypical type of pneumonia. You will get this dry cough and very milder flu-like symptoms. But when you look upon the X-ray are actually very much worse than the symptoms. Okay, the age groups you need to remember, it must be a patient from the college or from the dorm, or might be a military worker, or might be a patient from the prisons. And then you need to remember about this cold agglutinin. Because of this I antigen, there leads to the cross reactivity. The IgM reacts against the RBC, causing the hemolysis. And when you put the tube from the patient sample in the ice packs, what you will see is the clumping or the turbidity. And that's how you know the patient is having the cold agglutination. Okay. And the drugs, because you cannot give the penicillins, you need to give the patient macrolides, oxycyclines, or the fluoroquinolones. Any doubt?
No.
Okay. I think we should take a short break here, and then we'll start with the fungus and then finish the protozoas. Okay, a short break here.
Okay.
Okay, so we are finished with the bacteria, and now we are starting the mycology. Okay, and we have divided the fungi into 3-4 subtypes. First is the systemic fungi. Okay, second one is the cutaneous fungi. Third one is the opportunistic fungi. Okay, and yeah, that's it. 3 type of fungi. First are the systemic fungi, which affects your organs and the bloods. Second are the cutaneous fungi, which affects only your skin. Third are the opportunistic fungi, which only causes the infections when you are immunosuppressed. Okay, when you are immunocompromised. Okay, so first are the systemic mycosis, and I want to look at your first aids. And one of the important point is that all of the systemic fungi are the dimorphic fungi. Okay, they exist both in the mold form as well as in the yeast form, except for the coccidomycosis, which is a dimorphic fungi, but it do not exist in the yeast form. Okay, so all of them are the dimorphic fungi with mold and yeast. But for the coccidomycosis, they are dimorphic, but they are the mold and the spherules, not the yeast. Okay, outside the bodies, all of the systemic fungi, they exist in the mold form. Okay, and inside the body, they exist in the yeast form. But for the coccidomycosis, outside the body, they exist in the mold form, and inside the body, they exist in the spherule form. So whenever you take a biopsy of the patient from the lung or the or any organ they're affected, what you will see are the yeast, not the molds. Okay, and all of these systemic mycosis, they causes the pneumonia. Okay, and they also forms the caseating granuloma like the tuberculosis. Okay, and just but unlike the tuberculosis, they are PPD negative, because PPD is for the tuberculosis only. Okay, so all of them can cause the pneumonia. All of them can form the caseating granuloma, but they are PPD negative, and they cannot transmit from person to person. Very important part. Unlike the TB, they cannot transmit from person to person. The only way to acquire these infections is by the inhalation of the spores, and the spores are found in the surroundings at certain locations. We will discuss the locations later. Okay, so the spores are found in the surroundings, and you get the infection by inhalation of the spores. There won't be any person to person contact. Okay, and the dissemination will occur. Of course, initially you will get this pneumonia only. But if you become the immunocompromised patient, or you're the patient having the TNF alpha inhibitor therapy, like I told you, this TNF alpha is required, for the granuloma maintenance. So if you are the patient on the TNF alpha inhibitor therapy or the immunocompromised, then you're likely to get the disseminated infections at various organs. But all of them initially causes the pneumonia with the granuloma. Okay, so we have organized it into the themes. First, we will discuss the locations where the different fungi is found. Then we will discuss the yeast features, what you will see in the biopsy or the microscopy of the patient. Then we will discuss how the transmission of the disease occur. Okay, and finally, we will discuss the symptoms and then the diagnosis. So for the histoplasma, which is a dimorphic systemic fungi, it is found in the Ohio and the Mississippi River valleys. Very important. It is found in the Ohio and the Mississippi River Valley. So whenever a question is to describe a patient who is coming from these 2 locations, you will always think about the histoplasma. Okay, and you need to know the yeast feature, which is they are smaller than the RBCs. Very important, they are smaller than the RBCs. Okay, and that's why they are easily ingested or endocytosed by the macrophages or the monocytes. Okay, so what are the clinical presentation of the disease, they will all get the pneumonia with the hilar lymphadenopathy. And that's why I told you that pneumonia is just like the TB, because in both TB and the pneumonia, you will get the pneumonia and the hilar lymphadenopathy involvement. Okay. And then the disseminations, of course, occur whenever the patient become immunocompromised or the patient on the TNF-alpha inhibitor therapy. What they will get the dissemination through the reticuloendothelial system. Okay, and that's why it can go to your liver, can cause the hepatomegaly. Okay, they can infect the bone marrow of the patient, and that's why they can cause the pancytopenia. Okay, the patient can get the oral ulcers. Very important, the GI involvement. In the GI involvement, you will get the hepatosplenomegaly and the oral ulcers. And if the dissemination occurs to the bone marrow, the patient can get the pancytopenia. Okay, and generally transmission, the patient has a history of cave explorer or the bird contact. Okay, generally it could be a patient who is a cave explorer or the history of a patient with some kind of a bird contact, either as a pet. Okay, so very important. And when a dissemination occur, what you will get is the widespread calcified lesions, because ultimately these granulomas will be calcified, right? And what you will get is the widespread calcifications. And whenever the calcifications also involve the hilar lymph nodes, you can be damn well sure this must be a case of granulomas, disseminated granulomas. It could either happen in the tuberculosis or the tuberculosis-like diseases like systemic mycosis. Okay. So whenever a question is describe the involvement of hilar lymph nodes with widespread calcified lesions or widespread granulomas, it would be a disseminated infections from TB or the TB-like diseases. Okay. Then how you will detect the yeast? Well, you can do the urine antigen detection test. Remember one more area, in one more organism we have used this test, the urine antigen detection. Remember the name of the organism?
Legionella.
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 Exactly, Legionella. Yeah, exactly, Legionella. Okay, so Legionella, and in the histoplasma, you will do the urine antigen detection test. Okay, so what you will see in the chest X-ray of the patient, you will see the bilateral infiltrates. Okay, you will get the patchy consolidations, patchy infiltrates, and the hilar lymphadenopathy, of course. That's for the TB-like disease. And on the sputum microscopy, when you do the sputum examination, what you will see is the yeast that replicate in the macrophages. FA has a diagram, as you can refer to there. The diagram is showing the yeast which are in the macrophages. Like I told you, they are they have the size less than the size of RBCs. That means they can be easily phagocytosed by the macrophages. And what you will see is the yeast which are replicating within the macrophages, and that's why you get the granuloma formation, because your macrophages are not able to kill those fungi. Okay, and when you do the biopsy of the patient, like the like the lung biopsy, or might be the biopsy from the liver or from the oral ulcers, what you will see are the caseating granulomas. Okay, so for the sputum, what you will see are the yeast within the macrophages. As you can see in the diagram, it is a sputum of the patient. Okay, if you do the biopsy of the patient, what you will see are the caseating granulomas. If you do the chest X-ray of the patient, what you will see are the bilateral infiltrates with the hilar lymphadenopathy. If you do the urine examination, what you will see is the urine antigen positive. And for the symptoms, you will get the symptoms like the pneumonia, of course, you will get the cough, you will get the shortness of the breath. Okay, you will get the fatigue. Okay, and if you become immunocompromised, what you will get is the hepatosplenomegaly, pancytopenia, and the oral ulcers. Okay, any doubt? Any doubt, guys?
No.
No, it's okay.
Okay, then comes the blastomycosis. Okay, which is endemic in the eastern and the central US Great Lakes. Whenever a question time describe a patient with the eastern side or or the central United States, or it could be a patient from the Mississippi and Ohio also, because these areas generally overlap. Okay, so a patient from the Mississippi or Ohio can have histoplasmosis and can also have the blastomycosis. Okay, but a patient from the eastern or the central US Great Lakes, it must be the blastomycosis only. Okay, and you need to know the features of this yeast. they have the size which is exactly similar to the size of RBCs. Okay. And just like any other systemic mycosis, you will get the pneumonia, and the dissemination will occur whenever the patient becomes immunocompromised. And you need to know that the dissemination occurs in the skin and the bone. And for the skin, you will get the granulomatous ulcers and the warts. So the patient's skin become very ulcerative. The patient has these warts all over the body. And when you examine the warts or you do the ulcer scraping, what you will see are the granulomas. And that's why the name granulomatous ulcers and the warts. Easy to remember. And in the bone, you will get a bone pain. And if you do the bone biopsy, what you will see are the granulomas again. So for the diagnosis, you can do the sputum microscopy. What you will see are the broad-based budding yeast. As you can see in the diagram here, let me just zoom it. The base, you can see this area. This is the base of the fungi division, okay? And you will get a broad base, okay? This is a broad-based budding yeast, okay? Very important. Generally, when the budding happens, like in case of histoplasmosis or in case of any other fungi, the budding happen like that. This is one fungi, one yeast, and it has very narrow base, and then the other yeast. But in case of blastomycosis, this base is very broad, like that. Okay, that's how you can diagnose this thing again. Broad-based buzzing yeast, very important. Okay, and then for the skin biopsy or the lung biopsy in case of pneumonia, and skin biopsy in case of dissemination, what you will see is the caseating granulomas again. Okay, just like the histoplasmosis, you will get the caseating granuloma. Just know the location, the areas they are affecting, very much important. Okay, then comes the coccidomycosis. Like I told you, they are dimorphic fungi, but they have this mold form and the spherule form, not the yeast form. And they're endemic in the Southwest United States. Very important, they are endemic in the Southwest United States. So whenever a patient with the coccidomycosis present you, they're most probably from the location like California, Arizona, or might be the Mexico. These three locations are very important: Mexico, Arizona, and California. You will get the patient from one of these three locations. Okay, and you need to know that the RBCs are quite larger than the fungi is the yeast, or the spherules are larger than the size of RBCs, and that's why they cannot be engulfed by the macrophages. Okay, unlike the histoplasmosis. So what you will get in the clinical presentation, you will get the pneumonia, or sometimes you can even get the lung abscess. Okay, and yeah, you will get the pneumonia and lung abscess also in case of Klebsiella. Okay, but do not confuse between the Klebsiella and the coccidomycosis, because in coccidomycosis you will get the skin symptoms and the joint symptoms also, right? But in case of Klebsiella, you will get just the pneumonia and the abscess only. I've encountered a question over it where I confused this case with the Klebsiella, because they told me about this, very thick sputum, okay, and very thick colonies, and I confused it with the Klebsiella, but it was the case of coccidomycosis because the patient has a history from California and he's having this skin involvement also. Okay, so please aware of this fact. Okay, and yeah, you will get the skin rash if the dissemination occur, and you need to know that dissemination occur even in the immunocompetent patient, not just in the immunocompromised. The dissemination can also occur in the immunocompetent patient, and it will show as erythema nodosum, which is a bumpy nodules over the skin, very painful nodules over the skin. You will get reddish, and you can also get the erythema multiforme. Like I told you, you have this targetoid lesion in the erythema multiforme. So a skin rash, you will get the joint involvement, you will get the joint pain, and in the immunocompromised patient, you will get the meningitis. So only in the immunocompromised patient, you will get the meningitis, but you get the skin and the joint symptoms in case of normal patient, immunocompetent patient. Okay. And how you will make the diagnosis? You will first do the biopsy, and on the biopsy, you will get the granuloma formation. Okay. And you can do the biopsy from the skin rash. You can do the biopsy from the joints or lungs, of course. Okay, and for the sputum, you can do the sputum microscopy, and in the sputum microscopy, you will see the spherules which are containing the endospores. Very important, you will get the spherules which are containing the endospores. Okay, so the location will help you identify the disease, and of course the sputum analysis will help you identify the disease, but the symptoms are generally same in all three infections. Okay, and there's uh, one more fungi which is Paracoccidomycosis, and generally you found them in the Latin American areas, and it has this captain wheel like structure. Okay, and very easy to identify. It is a, as you can see in the diagram of the first aid, they have this captain wheel like appearance, where in the center of this wheel there is this mother yeast. Okay, let me draw this diagram for you. In the center you have this mother yeast. Okay, and the buddings are occurring at the periphery, just like that. These are the buddings. And that's why it has this captain wheel like appearance. In the center there is this mother yeast. Okay, and there is this budding formation occurring at the periphery, and it makes up the captain wheel like appearance. Okay, it presents to similar to the blastomycosis. You will have the pneumonia, you will have the symptoms like tuberculosis, and then you get the disseminated infections in the skin and in the joints. Okay, and which patients are very high risk of dissemination? The patient with a history of immunocompromisation like HIV, or the patient on the TNF alpha inhibitor therapy. And how will you treat the condition? You can give the patient azole drugs, which are fluconazole. Okay, and for the local infection, if the dissemination of the disease occur, you will always give the patient amphotericin B. So amphotericin B for the systemic infection, and for the localized infection like in the pneumonia, like in the lungs only, you will give the patient fluconazole or the itraconazole. Any doubt?
No, sir.
Okay, and now we study about the other fungi. So we have discussed the sorry. So we have discussed the systemic fungi, and now we are moving for the cutaneous fungi. Okay, and these are the fungi that affects your skin only, no systemic involvement. First is the tinnias, which are known as the dermatophytes, and three types are there, which are microsporum, trichophyton, and epidermophytons. Okay, three types: that microsporum, trichophyton, and epidermophytons. Okay, and please note this fact that you will always diagnose these cutaneous fungi by KOH preparation, also known as the wet mounts. Okay, potassium hydroxide preparation is very important to diagnose these fungi. Okay, and each of these fungi will cause the pruritus. Okay, it will affect the keratinized layer of the stratum corneum. Okay, it will affect the keratinized layer of your skin, which is the stratum corneum. Step 1 can ask you the location of the disease, and it would be a keratinized layer, which is the stratum corneum of the skin. All of these diseases affects the stratum corneum. Okay, and they do not invade the dermis, they just involve the epidermis. Okay, very important. So first one is the tinea capitis, which causes infection of the scalp. It causes a very pruritic type of rash over your scalp. Okay, and it can also lead to the alopecia. As you can see in this patient, this is fungi leading to the alopecia. Okay, then there is tinea corporis. Corporis causes the infection all over your body. Okay, so what you will get are some scaly ring-like lesions, as you can see here. These are the scaly ring-like lesions, and they have this scale, the linear linings. Let me zoom it here. These are the scales you are getting. Okay, so the scaly ring-like lesions you will get in case of tinea corporis. So corporis for the body, capitis for the scalp only. Okay, and of course we have this central clearing. That's why the ring form. Okay, and then comes the cutis, which affects only the inguinal area. Okay, very important. Only the inguinal area for the cutis. For the corporis, whole body has this O in its name, and that's why corporis also has the O in its name. So body corporis, you can remember by this fact. Then the curis for the inguinal area, both have U in their spelling, U and U for the curis and inguinal area. Okay, then comes the pedis. Pedis for the foot digits. Okay, so it would be intradigital. Okay, and then comes the tinea angum. Angum means nails, and that's why this is the fungi that affects only your nails. Also is the onychomycosis. Onychomycosis. Okay, so what are the treatment? Treatment includes terbinafine, either the cotrimazole or the miconazole, which are the azole drugs, or the graciofulvin drug. We will study about these drugs later in the antimicrobial parts. Okay, so graciofulvin could be given, terbinafine could be given, or azole drugs could also be given. Okay, so that's about the cutaneous fungi. And there is one more fungi which is not a group of Taenia, not a dermatophyte, but it is called the Taenia. Okay, but remember, it is not a dermatophyte. Very important. It does causes the pityriasis vesicolor. Okay, Tyriasis vesicolor it causes, and it is caused by the Malassezia furfur or the Malassezia species. Okay, it is a yeast-like fungus, but it is not a dermatophyte. Very important. Okay, and you need to know it is also a dimorphic fungi. Okay, you can list down the name of the dimorphic fungi. Is very important because step 1 can ask you about a dimorphic fungi. Okay, and you need to know that it inhibits a tyrosinase enzyme which involve in the melanin synthesis. Remember the reaction? Can anyone tell me the reaction? Anyone?
Tyrosine acted upon by tyrosinase produces melanin.
No, not a tyrosine, but a DOPA. Okay, dihydroxyphenyl acetate. The DOPA and the tyrosinase acts on the DOPA to convert it into the melanin. Okay, and this yeast, this fungus actually inhibits this enzyme, and that's why you will have this hypopigmentation of the skin. And you need to know that this hypopigmentation occur in very patchy areas. Okay, so you will get the patchy areas of hypopigmentation along with the mild pruritus. Okay, and generally the patient notice these kind of rashes when they have a history of sunburn or the sun exposure. Okay, so it would be a patient who is having a history of pruritus for a very long time, and after coming from a beach trip, okay, he got this sunburn or a hyperpigmentation of all over the skin except some patchy areas, and that's how you can diagnose this condition. Okay, so mild pruritic would be there. Okay, more common in summers, because at that time you will get the hyperpigmentation of all over the body except these hypopigmented areas. Okay, and when you do the potassium hydroxide wet mount, what you will see are the spaghetti and the meatball appearance. You will get this mold. Okay, because I told you it is a dimorphic fungi, you will get this mold as well as the yeast, and it is known as a spaghetti and the meatball appearance on the potassium hydroxide preparation of the scrapings. And what are the treatment? It would be the selenium sulfide. Okay, any doubt? Any doubt?
No.
Okay, so then comes the opportunistic fungi. We have discussed the systemic, we have discussed the cutaneous. Now we are discussing the opportunistic fungi, and let's start with them. First is the Candida albicans. You need to know that Candida albicans is also a dimorphic fungi. It can exist in the yeast form as well as in the mold form. Okay, their mold form forms the pseudo hyphase. Okay, generally the when you look for the mold forms, you have this kind of a mold. Okay, and this mold is divided into some kind of a hyphase. Okay, like that. Okay, as you can see. But in case of Candida, these hyphae are like that. Some patchy indentations would be there. Okay, but not the complete hyphae. That's why the name pseudo hyphase. Just the indentations are there in the hyphae, in the molds. Okay, these are the pseudo hyphae, and you will also get the yeast form. You will get the budding yeast. Okay, And you will also see the jump tube formation at the 37 degrees centigrade temperature. Very important. You will see the jump tube formation, which is like this is your yeast. And from this yeast, you are having this germ tube. Okay. This is the germ tube formation that you will see at the 37 degrees centigrade temperature. So 3 forms. First is the pseudohyphae. Second is the oval budding yeast. And third is the germ tube formation. Okay, and you need to know that it can do both, it can cause both the systemic infections as well as the superficial infection in case of immunocompromisation. And step 1 will ask you deficiency of what kind of WBCs causes the systemic infections, and deficiency of what kind of WBCs causing the superficial infections. So you need to know that neutrophils are important to prevent the Candida systemic infections. Okay, so in case of neutropenia only, you will get the systemic infections. Okay, the fungemia or the candidemia. Okay, so and that's a candida in the blood, and that only occurs when you become the deficient of neutrophils, neutropenia. And in case of lymphopenia for like HIV, you will only get the superficial infections. Very important, superficial infections in case of lymphopenia like HIV. And in case of neutropenia, like in case of any cancer treatment, because in case of chemotherapy, you're likely to become deficient of neutrophils. Okay, so neutropenia, so it would be a case of a patient who is receiving a chemotherapy and he's likely to get the neutropenia. So he will get this candida in the blood. Okay, and if the patient is HIV, then he will only get the superficial infections, which is a skin infections like oral thrush. Okay, so infections includes the oral thrush, like I told you, or the esophageal thrush. For the oral thrush, it would be a patient having some patchy whitish plaques in the oral cavity, and these plaques are very easily scrapable. You know, when you try to scrape these plaques, that they are very easily scrapable. Okay, so this is the oral thrush. And then you can get the esophageal thrush or the esophagitis. It would be an inflammation of your esophagus along with the whitish plaques over the inflammatory areas. So what you will get is a very painful swallowing. Okay, you will get very painful swallowing. Plus on the endoscopy, you will see very erythematous area in the esophagus, with these whitish plaques, which are very easily scrapable. Okay, so it would be a patient having a history of pain with the swallowing, and on the endoscopy you are having these erythematous areas with these patchy whitish plaques. This is the esophageal thrush. Okay, and you will only see them in the immunocompromised when you become deficient of the lymphocytes. Okay, and it could be a neonate, it could be a patient on the steroids, it could be a diabetic patient, or it could be a HIV patient. Okay, you will get the vulvovaginitis, and it would be an inflammation of your vagina. You will get a very thick whitish discharge from the vagina along with the inflammation. So you will have this pain in the vagina, you will have the pleuritic area in the vagina, you will have a thick discharge from the vagina, whitish cotton cheese like discharge. Okay, this is a vulvovaginitis. Okay, and remember I told you about vaginosis, which is not the inflammation, but it will have this a thin watery grayish discharge from the vagina. Okay, so please remember these facts. And vulvovaginitis, they can ask you how the patient would get this vulvovaginitis, what are the risk factors. So it would be a use of antibiotics. Okay, or it could be a patient with diabetes. Very important, a patient with diabetes or a recent antibiotic history or a recent antibiotic use will expose the patient to develop the vulvovaginitis. Very important. You can also get the diaper rash, okay, which is a rash in the inguinal region along with the skin folds. Very important. Whenever a patient, whenever a portion is describe a patient with a rash in the folds, in the inguinal folds. These are the diaper rash. Mostly happen in the in the infants, okay, who uses a diaper, of course. Then patient can also get the endocarditis if he has a history of IV drug use, because the candida actually a natural reservoir of your skin and your oral cavity. Okay, so just like the Staphylococcus aureus, which colonize your skin, if you do the IV drugs, and then you can inject the Staphylococcus aureus or the candida in the blood. So you can get the endocarditis. Okay. And like I told you, because they are the natural flora of your oral cavity. So generally when you do the sputum analysis of the patient for a pneumonia or like a COPD patient, this sputum will be contaminated by the Candida albicans in the oral cavity. So you will think that this pneumonias might be caused by the Candida albicans, but it's not the case. It's just a contaminant in the sputum. Very important. Okay, it's just a contaminant in the sputum. And why the contaminant? Because it is a part of your natural flora. Okay. Then you can get the disseminated candidiasis, like the candidemia, candida in the blood. Okay, especially in case of neutropenic patients. Like I told you, Esteban will ask you how you will get the superficial infections and how you will get the systemic infections. So for the systemic or the disseminated candidiasis, you need to have neutropenia. Okay. And in case of superficial infections, like I listed here, the like the oral thrush or the esophageal thrush, okay, or the vulvovaginitis, you need to have this lymphopenia. Okay. So what are the treatment? The treatment includes giving patient oral fluconazole, okay, and topical azoles for the vaginal infections, okay. And you can give the patient amphotericin B for the systemic infections. You need to know that any kind of systemic mycosis, whenever you have a disseminated mycosis, you will always give the patient amphotericin B. Okay. And you can also give the patient nystatin for this esophageal thrush or the oral thrush. Okay, nystatin. And fluconazole for the vaginal infections, very important. If they ask you what is the oral treatment of the vulvovaginitis, you will always answer the azoles. Okay, and if they ask you what is the topical treatment for the vulvovaginitis, what you will answer, either the nystatin or the topical azoles. Okay, so for the topical treatment, you can either give the patient azoles or the nystatins. And for the oral treatment of the vulvovaginitis, you always give the patient oral fluconazole, because oral nystatin is very toxic to your body. It has very high toxicity, and that's why you cannot give the patient orally or systemically. And amphotericin B for any systemic dissemination like candidemia. Whenever a question is describe a case of candidemia, you will always give the patient amphotericin B. There is one more disease caused by the candida, and this is the intertrigo, which is basically a very ulcerating type of rash, very pruritic type of rash that happens at the skin folds, like the axillae, or the groins or the inframammary folds. Okay. And it is an inflammatory condition, very important, generally affects the old age groups, very important. Okay. So yeah, that's it. That's about the Candida albicans. And the diaper rash, as you can see, you have this erythematous papules and pustules that affects the groins, the thighs, and the abdomens. And it generally seen in the babies using the diaper. And most importantly, they affect the groin folds. Okay. So whenever you have involvement of the groins and the folds there, it must be a diaper rash. Any doubt? Any doubt or anything you want me to repeat again?
I think we're good.
Now, just a second. Yeah, that's it. Then comes the Aspergillus fumigatus. And unlike the Candida albicans, it is not a dimorphic fungi. Very important point. It is not a dimorphic fungi. It can only exist in the mold form. And in the mold form, it has this septate hyphae. Okay, in the Candida albicans, you have the pseudo hyphae. In case of Aspergillus fumigatus, you have the septate hyphae, and that hyphae generally branch at the 45-degree acute angle, which is, let me show you, at the branching points. This is like hyphae or the mold of the Aspergillus fumigatus, and they branch at this 45-degree angle. Okay, so this angle is 45 acute angle. Okay, very important. And Yeah, just like the candida, it can cause a superficial infections and it can cause a systemic infections. And for the systemic infections, the patient must be a neutropenic patient. Okay, it must be a immunocompromised and neutropenic patient because neutrophil dysfunction are very much required for the invasive aspergillosis. Okay, and like I told you, this aspergillus is a catalase positive organism. So in the neutrophil dysfunction, you can get the chronic granulomatous disease in case of aspergillus. Okay, they will ask you the root of the infection by this by this aspergillus, and you need to know when you inhale the spores directly go to your lung. Okay, and in the lungs they can affect some pre-existing lung cavities which is caused by the TB. Remember I told you that the granulomas are responsible for the cavities in the TB in the lungs, and when the TB is kind of treated, the cavities would still be there, right? And this aspergillus can colonize these cavities, these pre-existing lung cavities, okay, and can cause the aspergilloma. Okay, so what you will see are the crackles, okay, or the hemoptysis in the patient because the inflammation inside your lung will be initiated again. So what you will get is the hemoptysis or the blood in the sputum. You will get the crackles in the lung, and when you do the patient's CT or the MRI of the chest, what you will see is the this cavity is formed or filled by the mass, with some kind of a mass. So that you will see. The patient will be having a history of TB, and what you will see are the cavity is now filled with some kind of a mass. So you will immediately know this that they're describing a case of Aspergillus fumigatus. Okay. So this is a local infection which is happen in case of a patient having a lymphopenia, and if the patient is having a neutropenia also, then the dissemination can occur through the bloodstream again. Like in case of candida, you can have a dissemination in case of neutropenia, like I told you. Okay, and you need to know that some species of the aspergillus also secretes aflatoxins, okay, which are responsible for the hepatocellular carcinomas. Okay, and aflatoxin generally patient give you a history of a farmer, then most probably a farmer who is a farmer of nuts. Okay, because it really contaminates the nuts. They release the aflatoxins in the nuts that can cause the hepatocellular carcinomas. Very important. Okay, and one more thing, they can also cause the allergic bronchopulmonary aspergillosis. Okay, in case of cystic fibrosis or in case of asthma, what happens? They regularly, colonize the lungs, and as a result, what you will get is a hypersensitivity reaction against the aspergillus. You will get the shortness of the breath, very severe type of shortness of the breath. You will get a very productive cough. You will get very the difficulty breathing. Okay, you will see in case of allergic bronchopulmonary aspergillosis, ABPA. Okay, and it must be a patient with a history of asthma or a patient with the cystic fibrosis, and with the regular infections by the aspergillus in ABPA. Ultimately, what will happen is the bronchiectasis. With the reinfections, with the keep on going inflammations, ultimately all the air spaces will be dilated, and what you will see is a bronchiectasis, very important. And because it is a allergic condition, what you will see is the eosinophilia and the very high IgE titer. Very important, you will see the high IgE titer and the eosinophilia. Okay, you will get the wheezing, shortness of breath, difficulty breathing, and the productive cough if the patient is asthma or the cystic fibrosis. So most probable case would be a patient having a history of asthma and now presenting to your emergency department with a sudden episode of asthma, a sudden episode of shortness of breath, wheezing, and and this cough, the productive cough. And okay, and so this is a case of allergic bronchopulmonary aspergillosis, and ultimately, eventually, the patient will develop the bronchiectasis because of the keep on going inflammations. Okay, and yeah, I think that's about it. And we need to know the pneumonia which is caused by the Aspergillus fumigatus. It's generally a lobar pneumonia. Okay, I will tell you one more fungus which causes a pneumonia, which is the Pneumocystis cerevisiae, and it causes the atypical type of pneumonia which affects both of the lungs. Okay, but in case of the Aspergillus, what you will see is the lobar pneumonia, which affects only one lobe, which affects only one lung and a part of that, unilateral lung. Okay, lobar pneumonia, very important. And I think there's one more thing I need to tell you about this, which is the invasive infections of the aspergillus. Okay, that generally happen in case of neutropenic patients only, like I already mentioned. And let me show you this. So first one is, so basically I've already described about the allergic bronchopulmonary aspergillosis, which is seen in the asthma and cystic fibrosis patient. What you will see is the acute exacerbations of the asthma, like I already told you, wheezing, rhinorrhea, shortness of breath, irritation in the eye. You will see in the labs, what you will see is the high IgE count and the eosinophilia. And ultimately, with the keep on infections, with the regular infections, what you will get is a bronchiectasis. Now, the invasive infections includes a chronic bronchopulmonary aspergillosis, okay, which is seen in the patient. This is different. This is a fungus ball I was talking about, the chronic bronchopulmonary aspergillosis. What happens when you inhale the fungus? It will colonize the cavities which are formed by the TB or might be the lung abscess. You need to know that both TB as well as the lung abscess can form the cavities, and these cavities can be colonized by the aspergillus. Okay, the patient could be asymptomatic, or the patient could develop the symptoms which includes a hemoptysis or the intermittent cough. Okay, and on the CT, what you will find is the pre-existing lung cavities that are now filled with some kind of a mass, and the mass is mobile, which means with with the direction of the patient, the mass will moves. Okay, it would be a mobile mass. Okay, and then comes invasive aspergilloma, which is seen in the neutropenic patient only. Like I told you, all the invasive infections will only occur in the neutropenic patients, and the neutropenia you will get by the chemotherapy. Okay, so you will get the symptoms just like the tuberculosis, which is the fever, the night sweats, the chest pain, and of course the blood in the sputum, which is hemoptysis. Okay, when you do the CT of the patient, what you will see is the halo sign, okay, which is a lung nodule. As you can see, this is a lung nodule, and it is surrounded by this, this hypodense or the glass opacities. This is a very hyperdense region, and this hyperdense region is surrounded by this hypodense region, as you can see. And this forms the ground glass opacity, which is a uniform like opacity, okay, uniform opacity, which is hypodense. Okay. And as you can see, this is a hyperdense region, which is a lung nodule surrounded by the hypoattenuation or the ground glass opacity. So whenever a question is describe a patient having a symptom of like fever, fatigue, weight loss, hemoptysis, night sweats, and the CT, they're describing some kind of a lung nodule with some ground glass opacity surrounding it. This must be the halo sign, and this must be a case of an invasive aspergilloma. So 3 diseases. One is the allergic or the exacerbations of the cystic fibrosis and asthma. Second one is basically seen in only patient with a history of tuberculosis or the lung abscess. And third one is in the patient having a history of chemotherapy. Okay, these 3 type of diseases exist in the Aspergillus fumigatus. And that's all what first aid mentioned. Any doubt?
No.
Okay, so now the Cryptococcus neoformans. Let me share the screen again. Okay, so now the Cryptococcus neoformans, and just like your Aspergillus fumigatus, it is also a monomorphic fungi, not a dimorphic fungi. But unlike the Aspergillus, it exists in the yeast form, not a mold form. Okay, and you need to know a very specific property of this yeast. It is a very highly capsulated yeast. Okay, it has a very thick polysaccharide capsule, as you can see here. This is your Cryptococcus yeast, and it is surrounded by this thick polysaccharide capsule. Okay, and like I told you, like any other capsule, it has this antiphagocytic function, of course. Okay, the capsule is for the antiphagocytic function. Very important. Okay, it is not dimorphic. It is found in the soil, and soils which are contaminated by the pigeon dropping. So patient is most likely to have a history of pigeon contact or a bird contact. Okay, just like the just like the histoplasmosis, you will also have a history of bird contact in case of Cryptococcus neoformans. Okay, and generally you acquire the infection through the inhalation, and in case of immuno compromised status, what you will get is a hematogenous dissemination. So what happens when you inhale the spores? They will enter the lung. In case of an immunocompetent patient, they will destroy these spores completely so that no symptom will be occurs. Okay, and the spores will be cleared by the T lymphocytes. All of the fungi are basically handled by the T lymphocytes only. No antibodies are involved. Okay. So in case of immunocompetent status, this infection will be cleared by the by the T lymphocytes and the macrophages very easily, and you will become asymptomatic. But in case of immunocompromised status, what you will get is the hematogenous dissemination of the infection, and finally the infection will reach to your brain, and what you will get is the meningitis. Very important, you will get the Cryptococcus meningitis. Okay, or the encephalitis. So you will get the meningitis and the encephalitis. Okay, if you're having some kind of a lesion in the brain parenchyma, that means it is an encephalitis which is affecting the brain completely. And if you're not having any involvement of the brain but the coverings of the brain, which means you will see a enhancement of the meninges of the brain, that means it is a case of meningitis. So in case of Cryptococcus neoformans, you can get the meningioencephalitis. Okay, very important. And yeah, that's it. And apart from the meningoencephalitis, you can also get the pneumonia. Very important, pneumonia and meningoencephalitis. Two things you need to remember about the Cryptococcus neoformans. And how will you diagnose the conditions? First, you can do the latex agglutination test, okay, which detects the antigens that are present in the polysaccharide capsule. Okay, so latex agglutination test which detects the antigen in the polysaccharide capsule. Second thing, you can do the culture of the fungus, and the culture you require the agar, which is Seborrheic agar, like I already mentioned in the very start of the chapters. Seborrheic agar you do for the culture, and you can do the sputum of the patient or the CSF analysis, and you can do the India ink staining. As you can see, the India ink staining is like that. You will have a very dark background, and these capsules are not stainable. Okay, the capsule will remain unstained, and that's why will appear as a halo or a clear space in the black background. Okay, this is a India ink test where you see the clear halos. Or you can do the Musi-Carmine staining, which is especially the staining for the capsules of the Cryptococcus neoformans. And in the Musi-Carmine staining, you will see this reddish capsule of the Cryptococcus. Apart from these two stainings, you can also do the H&E staining. Very important, you can do the H&E staining, and because their capsule is polysaccharide, it contains the glucose. So you can also do the PAS staining. So step 1 can give you either of the staining, either the India ink, either the Musi-Carmine, either the H&E staining or the PAS staining. Okay. And the most important test, if the step 1 asks you what is the test of choice, this would be a latex agglutination test for the polysaccharide antigen. Okay. And for the treatment, very important, you will give the patient amphotericin B along with the flucytosine, which is the 5-fluorouracil. Okay, amphotericin B and the flucytosine you will give patient. And this is the initiation dose, okay, followed by the fluconazole for the maintenance. Okay, so when the patient admits, you will give the patient amphotericin B and fluconazole, and after some time you will switch the patient to the fluconazole. Very important. And you also need to know that these fungi will replicate within the macrophages. Okay. And you also need to know that the meningitis in case of Cryptococcus neoformans takes some weeks to develop. Okay, it is not an acute type of condition. So generally, patient will give you a history of like 10 days or 12 days or maybe a month of history. Okay, because symptoms are very milder, and this disease is very slowly progressing. Okay, so generally, patient have a history of like 1 or 2 weeks of headache and mild fever. Okay, not the acute case, unlike the bacterial meningitis, where the patient generally has a history of like 2 or 4 days only. Okay, any doubt? Any doubt? Please respond.
No, sir.
Okay. Then comes the mucormycosis, which is mucor and the rhizopus. Okay, the black fungus you know nowadays. This is a mucormycosis. Okay, and you need to know that unlike the Aspergillus fumigatus, they have the mold, but their molds are non-septate. Their molds are non-septate and kind of a ribbon-like. They have very thick. And let me draw this for you. They have a very thick mold like this, like in shape of a ribbon. Okay, and their mold is without the hyphae, without these marking, as you can see here. This will seen in the Aspergillus only, but not in case of Cryptococcus neoformans. Okay, and one of the very important thing that you need to remember that they have the branching at the 90 degree. Very important, they have the branching like that at the 90 degree. Okay, a very thick broad base mold with a branching at the 90 degree. You will see in the biopsy of the patient. Okay, and what they cause is a mucormycosis. I'm sorry about that. Yeah, what you will see is some mucormycosis, which generally affects your nasal sinuses. Okay, it will first causes the sinusitis, which present as a facial pain and a mild fever and the running nose. And then soon you will get the involvement of the skin and you will get this necrosis overlying the sinuses. Okay, and this is a mucormycosis. It is a very painful condition, of course. Okay, and you will see this only in the patients having this diabetic ketoacidosis. And what kind of diabetes you will get a diabetic ketoacidosis?
Type 1.
Okay, so it must be a patient having a history of type 1 diabetes. Okay, if the patient has a history of type 2 diabetes, you won't get the mucormycosis. Okay, only in the type 1 diabetes you will get the mucormycosis. Okay, and so first thing is the ketoacidosis and second is the neutropenia. Okay, and how you will get the neutropenia? By the chemotherapy. Okay, so it could be a patient on the chemotherapy or a patient having a history of type 1 diabetes mellitus. Those patients can get the mucormycosis, where you get this sinusitis along with the overlying skin infection. Okay, you'll get this necrosis overlying the skin of the sinuses and the nose. Okay, it will affect your eye, can cause the blindness. And with this sinuses, they can also reach to your brain. Okay, and because the sinuses, the frontal sinus are involved, if in case, then you will have this frontal lobe abscess. Okay, or you get the cavernous sinus thrombosis. Remember the nerves that passes through the cavernous sinus? Anyone?
3, 4, 6.
Exactly, and 5B. 5-2 and 5-3. They also passes through the cavernous sinus. So we'll get the symptoms regarding these nerves, regarding this function of these nerves. Okay, and of course you will get the headache, you will get the facial pain because of the sinus involvement, and you will get a black necrotic scar on the face. And how will you diagnose the condition? They will ask you how you will take the samples. So it would be the skin biopsy. Okay, not the sputum analysis, not the running nose analysis. It's just the biopsy of the patient that you will do. And on the biopsy, you will see this thick molds, ribbon-like molds, and these are branching at the 90 degree. Unlike the Aspergillus fumigatus, which is branching at a 45-degree angle, and they have these septae. As let me zoom it. As you can see, these are the septae of the Aspergillus, but these septae are absent in the mucormycosis. And you need to know, guys, that similar disease can be caused by the Aspergillus fumigatus. Aspergillus fumigatus can cause the same mucormycosis like disease. It will cause the sinus involvement. You will have the facial pain. You will have the black necrotic scar also in case of Aspergillus fumigatus. But only in the mucormycosis, you will have this ribbon-like molds and the branching at 90 degrees. So, diagnosis is very important. Okay, please look for the scrapings. Please look for the biopsy. do not just rush for the mucormycosis if you heard this necrotic scar thing. Okay, both of them can cause the disease, but you just need to know, learn from the biopsy only. I have mentioned it already. Aspergillus can also cause the rhinosinusitis, similar to the mucormycosis with similar presentations. So you need the biopsy to differentiate between the two. Okay. Okay, and yeah, and because Cryptococcus neoformans can exist only in the yeast form, they do not form any hyphae or the pseudo hyphae. They are just a budding yeast, as you can see the budding here. Okay, and these are the germ tube formations from the Candida. Okay, and this is the oral thrush. As you can see, this whitish plaques all over the oral cavity. And these are generally seen in the patients who are immunocompromised, means the patients who are taking the glucocorticoid therapies or the patients with HIV, they are likely to get the oral thrush because of the lymphopenia. And neutropenia is responsible for the invasive infections like candidemia. Okay, and just like in case of Aspergillus fumigatus, you will get the invasive aspergillosis in the immunocompromised patients. And what are the symptoms for the invasive aspergillosis? You will get the fever, night sweats, weight loss, and hemoptysis, productive cough. And on the chest X-ray, what you will see is the halos with a lung nodule. Okay, a central lung nodule which is very hyper dense, surrounded by a hypodense region. Any doubt on this page? Any doubt on this page?
No, sir.
Okay,
No, sir.
then comes a pneumocystis herovesi. It is not girovesi, but the herovesi. Okay, pneumocystis herovesi, which only affects the AIDS patient or a immunocompromised patient, like patient with glucocorticoid therapy, of course. They causes the bilateral diffuse interstitial pneumonia. Okay, it affects the interstitium space, which is a space between the different alveoli. Okay, it affects the interstitium space, and that's why causing the diffuse interstitial pneumonia. Just like the atypical type of pneumonia, the patient has a history of non-productive type cough. And on the chest X-ray of the patient, you will have the patchy bilateral involvement of the lungs. And this is known as the ground glass opacification or the ground glass consolidation. Okay, so bilateral ground glass opacities on the chest imaging, on the X-ray, and on the on the CT. As you can see, the bilateral opacities are there. Okay, these are the opacities, these whitish areas, and these are the air spaces, airways. Okay, these are the opacities, whitish areas. So that you will see in the X-ray and the MRI of the patient. Okay, and yeah, so what you will see and the history, the patient will have a history of HIV or maybe a history of glucocorticoid therapy. The patient will present you with symptoms like chest pain, and this cough, a non-productive type cough or the dry cough, and on the chest auscultation, what you will see is the bilateral crackles, and that on the chest X-ray you will see the bilateral opacification of the X-ray. As you can see, these are the opified regions, bilaterally they are present. On the CT MRI, what you will see is the ground glass opacities. Okay, and please remember, in case of Aspergillus pneumonia, it is a lobar pneumonia, so it will affect just a lobe, and you will get opacity like that. You will get the opacity like this area completely, and the rest of the area is absolutely normal. Okay, but in case of pneumocystis cerevisiae, it would be a bilateral involvement. Okay, and what stains would you use? Okay, like in case of this, in case of Cryptococcus neoformans, you use the mucicarmine stain, right? But in case of pneumocystis cerevisiae, you use some methenamine silver stain. Very important, methenamine silver stain. Okay, and you can also use this fluorescent antibody staining. You can also, yeah, that's it. So on the methenamine silver staining, what you will see is a disc-shaped yeast. These are the disc-shaped yeasts that you will see on the methenamine silver staining. Okay, and along with this bluish background, bluish greenish background. Okay, and what are the treatment? Treatment is very important for pneumocystis cerevisiae. and you require this trimethoprim sulfamethoxazole. These are the antibacterial agents that are working in the fungus. Okay, so trimethoprim sulfamethoxazole, and if the patient has allergy of sulfonamides, then you can give the patient dapsone. Okay, in case of TMP SMX allergy, you can give the patient dapsone also. Okay, and you need to start the prophylaxis as soon as your CD4 count drops to less than 200. So step 1 will ask you if there's a patient who comes to your department with a history of HIV, and now he's having a CD4 count of less than 200, what drug would you initiate? What against which of the organism you will initiate the prophylaxis? So it would be the Pneumocystis cerevisiae. Remember what infections you will get when you drop CD4 count less than 50? What bacterial infections we have talked about?
Mycobacterium avium complex.
Yeah, MAC. Okay, and in case of less than 200, you will get the Pneumocystis cerevisiae. So you need to start the prophylaxis for these agents. Okay, so yeah, I think that's it about the Pneumocystis cerevisiae. Then one more fungi, which is a dimorphic fungi, and this is the Sporothrix schanski. Okay, and this causes a sporotrichosis. Okay, it is a cigar-shaped yeast. You just need to remember the buzzword, the buzz name, which is cigar-shaped yeast. Okay, in the human body, and of course the hyphae in the outside the body. So outside the body you will get the hyphae, and inside the body you will get the cigar shape. Okay, they are most commonly traumatic implantation. You will get the implantation of this fungi in your skin by a trauma, and this trauma is most commonly occurred by a thorn. Okay, which is most commonly present on the roses, a thorn on the rose. So it would be a gardener. It will always gonna be a case of gardener in the step 1 to, okay, a rose gardener. That's why known as a rose gardener's disease. Okay, and when it traumatically introduced in the body, it travels through your skin and through your lymphatics, and causing the pustules, and the ulcers or the nodules in the ascending fashion. So like if you get injured by a thorn pick, like at the wrist, so starting from the wrist up to the axilla, what you will get are the ulcers or the nodule formation, or the local pustules in the ascending fashion. Okay, like from the wrist to the axilla. Okay, and you need to know that the fungi actually goes to the lymphatics. Okay, and that's why causing the ascending lymphangitis. What you will get are the subcutaneous nodules and the ulcers along the lymphatic drainage pathways. Okay, what are the treatment? Treatment includes itraconazole or the potassium iodide, and just like any other fungi, if you take the biopsy of the patient, what you will get is the granuloma. Okay, so initial lesion would be a reddish nodule, which will become ulcerated later. Okay, and it is a dimorphic fungi. Any doubt? Please respond. Any doubt?
No, sir.
Okay, so we have finished with the fungi. We have discussed the dimorphic fungi. You need to remember the list of dimorphic fungi. That includes Sporothrix schanski. That includes your Candida. Okay, that includes your Malassezia furfur, and includes your systemic mycosis. Then you need to know what fungi affects only your skin, what fungi affects your whole body, systemic fungi, that means, and what fungi only affects when you become the immunocompromised. That includes your Candida, Aspergillus, Cryptococcus, Mucormycosis, or the Pneumocystis. Okay, you need to know how to diagnose these conditions. You need to know the locations, the demographics of the patients. You need to know when the lymphopenia occur, what diseases could be happen. When the neutropenia occur, what diseases could be happen. Okay, and then you need to know what you will get in the biopsy of the patients. Okay, who will form the these germ tubes, who will form the 45-degree angles in the mold, who will form the 90-degree angles. You need to remember the name of different stains, like methenamine silver stain, like mucicarmine stain, like PAS staining, H&D staining, or the India ink staining. You need to remember about the Seborrheic agar, and yeah, that would be it. We are finished with the fungus, and we will start with the protozoas now, the parasitology. I think we can take a short break of 5 minutes.
Yes.
Okay. Yeah. Sure. Okay, so before studying the parasitology, I want you to write down the names, with a with a proper organization of every protozoas and every helminthics, and every kind of disease they cause. Because remembering the name of these parasites are more important than knowing their diseases. Because it is a kind of a very hard to memorize every one of them, right? So we will start with with the protozoas. Okay, and let me just open a file where I have made these names. Okay, so first come your protozoas, then we will study about the helminthics. Okay, so two type of parasites. First are the protozoas, then the helminthics, and then we'll study about the ectoparasites. So for the protozoas, protozoas can be differentiated into protozoas that affects your GIT, that includes your Giardia, and amoeba, or the Cryptosporidium. Okay. Then the protozoas that affects the central nervous system, that includes the Toxoplasma, the Naegleria, and the Trypanosoma brucei. Okay. Then comes the protozoas that affects the bloodstream. Okay. These are Plasmodiums and the Babesia, Plasmodium vivalovix, Plasmodium falciparum, Plasmodium malariae, and the Babesia. Okay. Then the other protozoas, which are the which affects the other organs, like Trypanosoma cruzi affects your heart, and the Leishmania, which affects mainly the skin. Okay. Then comes the protozoas that transmit through the STDs. Okay, and these are the Trichomonas vaginalis. Okay. Then we will study about the helminthic and their roots you should know. So through the orophycal, you will get the EA-T-T, which is the Enterobius, Ascaris, the Trichiniella, and the Toxocara. Okay, Enterobius, Ascaris, Trichiniella, and Toxocara. Then through the skins, you can remember him by the mnemonic SAND, which is the Strongyloids, the Encylomat, the Ancylostoma, and the Nicator. Okay. Then the helminthics that transmit through the bites. Okay, and you can remember them by the mnemonic lay low to avoid bite, which is LOW only, Loa, Onchocerca, and the Wuchereria. Okay. Then the cystodes. Okay. These are the nematodes we have told about, the helminthic roots. These all are the nematodes. Okay. And the type of helminthics. Okay, these are the nematodes. Then comes the cystodes, which includes the Taenia, the Diphyllobothrium latum, and the Echinococcus. Okay. Then the trematodes, which includes the Schistosomia hematobium and Schistosomia mansoni, and the Clonorchis sinensis. Okay, and finally the ectoparasites, that includes the Sarcoptes scabi and the Thyrus pubis and Pediculus humanus capitis. Okay. So it would be better if you write all these names in a single paper, like a summary, because remembering name is much more important. Because only if you remember the name, you can remember the disease they cause. Okay, and let me just go back to the first aid. And this is how your first aid is organized. First, we will study about the protozoas that are affecting your GI system. Okay, and that includes the Giardia, the Entamoeba histolytica, and the Cryptosporidium. So remember the antibody that fight against this Giardia. Remember the name of the antibody?
IgA.
IgA.
So we'll get the recurrent infections from the Giardia in case of IgA deficiency, which could be happen in case of proton tyrosine kinase X deficiency, or might be the selective IgA deficiency case. Okay. And with the Giardia, because it infects your GI tract, so what you will get is a diarrhea, and it is generally a fatty, foul smelly diarrhea because it causes the fat malabsorption. Okay, so what you will get is a fatty, foul smelly diarrhea. Okay, you will get the bloating sensations, you will get the flatulence. Okay, and it is often seen in the campers or the hikers. So whenever a question stem describe a patient with a history of some kind of a traveling to a jungles or a camping history, okay, or might be the history of hiker, okay, and he's then having a history of diarrhea for like 1 week or 2 weeks. You need to remember the timeline because they have the diarrhea for like 1 week or 2 weeks, with 10 to 14 days of diarrhea, or even a month of diarrhea they can have in case of immunodeficiency. Okay, so this would be your giardia, and the transmission will occur due to the contaminated water. Okay, most probably the mountain water, and these are the cysts in the water you need to know. And how you will make the diagnosis? Well, in the stool examination, what you will see is the multinucleated trophocytes, okay, or the cyst in the stool. These are the trophocytes of the giardia. As you can see, there are the two nucleuses here. So they are the multinucleated trophocytes. Okay. Every protozoa, as you can see here, they have the trophozoites. Okay. So, and the trophozoite of the giardia are multinucleated. Or you can do the antigen detection, of course. Okay. The treatment of every GI infection caused by the by these protozoas includes a metronidazole, except for the Cryptosporidium, which uses the netoxamide. You will study that later. So metronidazole is important. Okay. Then comes the Entamoeba histolytica. Apart from infecting your GI tract, the intestines, they also affect your liver. Okay. So it would be a amoebiasis dysentery, where it causes a bloody diarrhea. Okay. As well as a liver abscess. After infecting your GI tract, after infecting the intestines, they affect the liver and causing the liver abscess. So with the liver abscess, what you will get is a right upper quadrant pain, hepatomegaly you will see, okay, and you will get a bloody diarrhea, of course. And when you do the biopsy of the GI tract, what you will see is a flask-shaped ulcer, which is, let me draw it for you, or I have already drawn a diagram here. You can see it here. Let me zoom it. These are the flask-shaped ulcer. This is the epithelium of the GI tract. Okay, and this is a very narrow opening, as you can see, and a very broad base ulcers. Okay, these are the flask-shaped ulcers that you will see in the biopsy of the patient. Okay, on the stool examinations, you need to know that they have the trophozoites, which are filled with the RBCs. Basically, the trophozoites actually ingest the RBCs, as you can see. And you can remember them by the mnemonic that Entamoeba eats Entamoeba eats erythrocytes. Okay, very important. And this is a cyst of the this is it. Okay, and this is a cyst of the of this Entamoeba. As you can see, they are this multiple nuclei. Okay, this is also very important. Just like the giardia, their cysts are also multinucleated, and they can have up to 4 nuclei in the stools. Okay, the two things, their trophozoites can engulf the RBCs. Okay, and the cysts have this multinucleated structures. Okay, and they have this flask-shaped ulcer in the GI tract. On the biopsy, you can find it. You will have this bloody diarrhea, and it can also affect your liver, can cause a right upper quadrant pain or the liver abscess, of course. Okay, and how the transmission occurs? Well, after entering your intestine, they will invade your intestine, they will enter the portal circulation, and you know that the portal blood will always go to the liver, and that's where the causes the liver abscess. Step 1 will ask you this pathway. First the intestine, then they will invade going to your liver via portal circulations. Okay, and what treatment would you give? It would be the metronidazole. Okay, and you need to know about this paromycin for the asymptomatic cysts that are present in the GI tract. Okay, the residual cyst in the GI tract, in the GI lumen, it would be eliminated by the paromycin. Okay, so metronidazole and the paromycin you will give to the patients. Then comes the Cryptosporidium, which causes the diarrhea mainly in the immunocompromised patients. Okay, it will cause the very severe diarrhea, the life-threatening diarrhea in case of AIDS. And you need to know that they will cause very mild watery diarrhea in case of immunocompetent patients. So patients generally have a history of like the diarrhea for like a month. Okay, and yeah, and you need to know one fact about this Cryptosporidium, that they are acid fast positive. Okay, just like the tuberculosis, they can be stained with the acid fast staining. As you can see, every acid fast staining had this bluish background, and the pinkish organism. In case of bacteria, it would be a pinkish kind of bacteria. In case of this Cryptosporidium, it is this, the pinkish type. And you need to know that their cysts actually line the epithelium of the GI tract. For example, let me show you. If this is a epithelial cell, enterocyte, then you can find on the biopsy cysts like these, lining the cells. Okay, and there you have the inflammatory cells within the lymphatics. This is the epithelium complete. This is epithelium, this is the lymphatics, and you have this inflammatory cells in it. Okay, and that's it. And you need to know that the immunity is driven by the CD8 positive cells. Very important point again. Okay, so inflammatory infiltrate in the lamina propria, and on the surface of the epithelium, they are found the cysts of this Cryptosporidium. And you use the drug nitazoxanide for the treatment of the Cryptosporidium. Very important. Okay, I think that's it about the Cryptosporidium. Any doubt? So if they mention any organism, which is causing the GI symptoms, the diarrhea in case of AIDS, and the diarrhea is a watery diarrhea. Okay, and you see the inflammation in the small intestine of the patient, it will always gonna be a case of a Cryptosporidium, especially if they give you a case of acid fast staining. And you can differentiate it by the these MAC complex, the Mycobacterium avium intercellulare, by the fact that they do not infect any other organ, unlike the Mycobacterium. In case of Mycobacterium, you can have the diarrhea, you can have the acid fast staining organism, but you can also have the lymphadenopathy involving multiple areas of the body, as well as the fever, night sweats, and the weight loss would also be there. And the lung involvement will also be there in case of MAC, but not in case of Cryptosporidium. Any doubt?
No.
Okay, so yeah, that's about the GI parasites. And then we will move forward and we will study about the CNS parasites. First is the Toxoplasma gondii. Okay, and you need to know that it only affects the it can affect the immunocompetent patients, and there it can cause the infectious mononucleosis. Remember what virus causes the infectious mononucleosis?
Epstein-Barr virus.
Or any other virus apart from Epstein-Barr virus? Exactly, cytomegalovirus. Yes. And even the hepatitis virus can cause the infectious mononucleosis. For other additional information, okay, so Toxoplasma gondii can also causes the symptoms like the infectious mononucleosis, where you have this running nose and the liver involvement and the pharyngitis thing. Okay, but the heterophile antibody test would be negative, because heterophile antibody test would only be positive in case of Epstein-Barr virus only. Okay, and you have the reactivation syndrome in case of AIDS patient, where you can find the brain abscess. How a brain abscess will present you in the CT or MRI when you look for the brain abscess. Let me just draw it. If this is the brain of the patient, okay, you have this halo area, which containing the abscess. Okay, and this abscess is lined by the some kind of epithelial lining. Okay, so they're generally seen as a ring enhancing lesions. Okay, let me just show you again. These are the ring enhancing lesions, as you can see. This is central hollow part, which includes the abscess area, abscessized area, and this is the reactions which are just encasing this abscess, and this is seen as the hyperdense regions. So this is a ring enhancing lesion, and especially in case of this Toxoplasma gondii, you will get the multiple ring enhancing lesions in the brain. Okay, so whenever you encounter a patient having some CNS symptoms, and because they're damaging your they're damaging your brain parenchyma, what you can expect is a paralysis or the focal neurologic deficits, right? So you can have a patient having a focal neurologic deficits or the paralysis thing, and when you do the MRI, you will find this multiple ring enhancing lesions. And whenever you get a multiple ring enhancing lesion, you will always think about the Toxoplasma gondii. There is one more case where you can get the ring enhancing lesion in case of a tumor. Anyone remember the name?
Yes, primary CNS lymphoma.
Yeah, primary CNS lymphoma, you can get the ring enhancing lesion. But in case of primary CNS lymphoma, what you will get a single ring enhancing lesion. Although you can get a multiple ring enhancing lesion also, but it is kind of rare. Okay. In case of this Toxoplasma gondii, you will get a multiple ring enhancing lesion most commonly. But in case of primary CNS lymphoma, it would be a single solitary lesion. Okay. And not just in case of Toxoplasma gondii or the primary CNS lymphoma, anytime you have the brain abscess, like I told you, in case of brain abscess, you have this central hollow area surrounding by this enhanced area. Whenever you have a brain abscess, you can expect a ring enhancing lesion. Okay. And this could be a case of your bacterial abscess. This could be a case of a fungal abscess. Like I told you in the mucormycosis, you can have this ring enhancing lesion. Okay. In case of a tumor like glioblastoma multiforme, you can have a ring enhancing lesion. Okay. So don't confuse. You just cannot see this ring enhancing lesion only in the Toxoplasma or the primary CNS lymphoma. Any kind of abscess, they can cause this ring enhancing lesions. And the most common cause of these ring enhancing lesions are the bacterial abscesses. Okay. And you need to know about the congenital toxoplasmosis. Very important. They causes a classical triad of the chorioretinitis, the hydrocephalus, and you will get the intracranial calcifications, which means a calcification within the parenchyma of the brain. You will see in the CT or the MRI, you will see the intracranial calcifications. Very important to know the locations of these calcifications, because you will encounter a case of cytomegalovirus where you have this paraventricular calcifications. You will encounter a case of other virus, the Zika virus. Okay, where you have this, these subcortical calcifications. Okay, so you need to know the locations of the calcifications, and you will get a chorioretinitis, which is basically the inflammation of the retina. So what you will get on the fundoscopy are some, the cotton wool-like spots in the retina would be seen, and the hydrocephalus. Okay, how will you acquire the infection of the Toxoplasma? This would be the cyst in the meat, and which is contaminated by the cat feces. So the patient most probably would have a history of cat contact. Okay. And that's why the mothers, the pregnant females, are always advised to stay away from the cats in the pregnancy. Okay, because they can likely to get the Toxoplasma gondii. Okay, so it could be a patient who handles a litter of the cat. It could be a patient who has a history of a cat as a pet. Okay, it could be a patient who is in a heavy history of contaminated meat. Okay, so they can give you a history of cat, or they can give you a history of contaminated meat. Both are equally important. Okay, and they most probably ask you about this thing. They will give you a patient having a history of Toxoplasma gondii, and they will ask you how he will likely to acquire the infection. So either they will list down the this cat thing, or they can list down the contaminated meat. Do not get confused. Okay, so on the serology or on the biopsy of the patient, you will get this crescent, this this kind of a structure of the organism. This is a crescent shape. Okay, so on the biopsy of the patient, what you will see is a crescent shape like organism, and it is intracellular. Very important. These are the intracellular organisms. So in case of a congenital toxoplasmosis, when you do the placental biopsy, what you will find are the crescent shaped intracellular structures or the organism. Okay, and this would be the Toxoplasma gondii. Very important. Let me show you. Sorry. If the FA has a diagram. Yeah, that's it. This is a crescent shape organism. Okay, and for the treatment, you will give the patient sulfadiazine and the pyrimethamine. Remember the mechanism of action of the pyrimethamine? Anyone? The mechanism of action of the pyrimethamine? I told you about 3 drugs.
Folate.
Yeah.
Folate.
Dihydrofolate
Yeah.
reductase inhibitor.
And what enzyme? Dihydrofolate reductase. Yes. So pyrimethamine, methotrexate, and trimethoprim, they works in the same way. Okay. And yeah, that's about the Toxoplasma gondii. Any doubt? Any doubt?
No.
Okay, so then comes a Naegleria fowleri, okay, which causes the meningoencephalitis, which means the inflammation of the meninges as well as the encephalon, which is your brain parenchyma. Okay, and because you're involving a brain parenchyma, you can have a focal neurologic deficits, you can have this paralysis, and because you're involving the meninges, you can expect the symptoms like the meningitis. And you need to know that this organism actually get inside your body through the swimming. Okay, so it would be a patient having a history of swimming or might be a swimmer, okay, or something like that. And you need to know after inhaling the water, what happens is that this parasite will actually pierce through the cribriform plate, okay, from the nose. So first it from the nose, it will enter your nose, then it will passes through the cribriform plate, and then through the olfactory nerve, it reaches to your brain. Okay, from the olfactory nerve, very important to know the name of the nerve. Olfactory nerve, it reaches to your temporal lobes of the lung, or might be the frontal lobe. It can affect the frontal lobe, it can affect the temporal lobe. Okay, so on the imaging, what you can expect, the inflammation in the frontal lobe, like I told you, or the inflammation in the temporal lobe, which could be seen as an enhancing mass within the lung, within the brain. You will see as the enhancing mass. Okay, and that's why the disease is also known as a primary amoebic meningoencephalitis. Because, and you need to know that in the CSF examination, because we have this meningitis also. So in the CSF examination, what you will see is the amoebas. So step one will give you a case of a patient who is having a history of meningitis, and he's a swimmer. And on the CSF examination, you are having this amoebas. Okay, so this would be a case of Naegleria fowleri. And once you get this infection, you need to know that it is very rapidly fatal. Okay, more than 99% of times the death will occur. Okay, and you can prevent the disease by giving the patient amphotericin B in a timely manner. But generally, all the therapies has been failed, so it is only affected for few survivors only. Okay, nearly all cases are fatal. So very important to know the root of the infection. Very important to know how the infection is acquired, the symptoms. Okay, symptoms like the meningitis only, and they will tell you the CSF examination, they have found this high neutrophil count, or the high, sorry, not the neutrophil, but the high lymphocytic count they have been getting. Okay, very high protein content, very low glucose content, but no bacteria, but the amoebas are found. Okay, and that means it must be a case of Naegleria fowleri. Cases are rapidly fatal. You can expect a death even after giving the drug. Then comes a Trypanosoma brucei, and you need to know the difference between the brucei and the cruzi. Very confusing names. Okay, the brucei causes the African sleeping sickness, which you will die in the sleep. Okay, what happens when you acquire the infection? You have this, you have this progressive weakness. Okay, the patient become very somnolent. He become very sleepy, and ultimately inside the sleep they goes to the coma, and finally they get death. Okay, so what you get is the recurring fever. Okay, you will get the fever multiple times. The patient become, keep on very fatigue, weakness, and ultimately they will die in the sleep. And they will ask you how the patient will acquire the infection. It is by the CC fly. Okay, and you need to know that it is a painful bite, so the patient is most likely to remember the encounter. Okay, CC fly, very important. And then they will give you the the diagram, the figure of the organ, this organism. And as you can see, this is the trypomastigoid. Okay, and this will found in the blood smear of the patient, the trypomastigoid. The same trypomastigoid you will see in the Trypanosoma cruzi, but cruzi involves the heart, the cardium, CC. Brucei affects the brain, BB, and cruzi affects the heart, cardium, CC. Okay, and CC fly for the Trypanosoma brucei, very important. And you must remember this figure. Okay, this is the trypomastigoid. Okay, very important. Any doubt?
Do we need to remember the treatment of this Trypanosoma brucei?
No, no treatment. Don't worry about it. Just the names are given. Just the 2 treatments here and 3 treatments previously. You don't need to remember the treatment of Trypanosoma brucei. Okay, so then the protozoas, which affects your blood, of course, and these are the Plasmodium and the Babesia. Okay, Plasmodium causes the malaria, and you need to know the mosquito name, which is the Anopheles mosquito. Okay, and the dengue is caused, and the dengue and chikungunya is caused by the Aedes mosquito. Okay, so Aedes for the viruses and Anopheles for the Plasmodium. Okay, very important thing to know. So 4 types of this plasmodium exist. One is the vival and ovex. Second is the falciparum. Sorry, one is the vival, second is the oval, third is the falciparum, and fourth is the malaria. You don't need to remember about this 48-hour cycle or a 72-hour cycle. Okay, don't need to worry about that. But you do need to know that this oval and vivax have a dormant form in the liver. So they can basically become latent in the liver for like 2, 3, 4, or 6 months. And after 6, 7 months, their reinfection will occur. A reactivation of these protozoas will occur, and you will get the symptoms again. Okay, so you need to remember only the vivax and the oval have this dormant form. And you need to know that this in India, the vivax and oval are very predominant, these plasmodiums. Okay, so whenever you encounter a patient from having a traveling history from the India, they're most probably giving you a case of vivax and oval, and sometimes they will give you a case of falciparum. But you need to know that this falciparum is kind of dormant strain in the Africa. Okay, so whenever you encounter a patient from the Africa, they are most probably giving you a case of falciparum, and from India they can give you a case of vivax oval or the falciparum both. Okay, and you need to know that this almost all strains of the falciparum become resistant to the chloroquine. Okay, so whenever step 1 asks you a treatment of this Plasmodium falciparum, you do not give the patient chloroquine, but you give the patient atrovaquone or the proguanil. Okay, very important, atrovaquone or the proguanil. Okay, and then you need to know how the cycle of this Plasmodium works. So basically, when the mosquito bite you, they basically secretes these sporozoites in your body. Okay, then the sporozoites will go to the liver and become the hypnozoites. Okay, very important. And finally, the activation of these hypnozoites occur. They become the trophozoites, which affects your RBCs, and these are the trophozoites which become this ring stage. The ring things that you detect in the RBCs, these are the trophozoites. Okay, please remember, in the liver, these are the hypnozoites which affects the liver. Okay, and the sporozoites which enters your body. Sporozoites will go to the liver and become the hypnozoites. Then the activation of these hypnozoites will occur. They will become the trophozoites to affect the RBCs. Okay, so yeah, and you need to know that this falciparum can cause a very the complication, which is a cellular malaria. What happens in this case is you get the occlusion of the capillaries, because you're getting the homolysis of the RBCs, right? You're getting the homolysis of the RBCs, and that's why the thrombosis will occur, and finally the occlusion of the capillaries will also occur in the brain. Okay, RBCs will rupture and they will occlude the capillaries in the brain, so you will get the cerebral malaria. So in case of CSF examination, what you will get? You will get nothing. Okay, because it is not a meningitis, it's nausea encephalitis. You're not having any organism in the CSF. But in order to detect the organism, you need to look at the peripheral blood smear only. Okay, this is a very important thing. And only in case of vivax or oval, you will get this Schnuffer stifling, which is a stifling in the RBCs. Okay, and you get this one more thing that I want to tell you guys, that you can expect a double ring, double dot ring in case of falciparum, and single ring in case of vivax and oval. Okay, double dot ring in case of falciparum and single dot ring in case of vivax and oval. It is the most common thing, but not always, but most commonly you get a single ring. Okay, and also the gametocyte of this falciparum you can expect in the exam, and it would be a banana shaped gamete, the crescent shape, or okay, which is a characteristic for the falciparum. And they will give you a history of a patient. who has taken the prophylaxis. And for the prophylaxis, you need to know that you always give the patient mefloquine, most important. Okay, so it would be a patient who has taken the mefloquine and visited the India or the African countries, and after returning back, he basically stopped the mefloquine. Okay, and after 7 or 8 days later, he started having these symptoms again of this malaria. So they will ask you why the patient is having symptoms, although he has already taken the mefloquine. Why does the patient is having symptoms? Okay, so you need to know that this mefloquine is only active against the blood infections. Okay, they are not active against the liver forms. Very important that this mefloquine is only activated against the liver, only activated against the blood forms, not against the liver forms. Okay, and that's why you can expect this release of these schizones from the liver for up to 4 weeks. Very important, you can expect a release of the schizones from the liver for up to 4 weeks. So the patient must take the prophylaxis for 4 weeks after returning. If they stop in between, then the release of the schizones will occur from the liver and the patient can get the malaria. Okay, so very important to know that that this mefloquine can only destroy the parasites within the RBCs. They have no activity against the liver, and even after returning from the country, you can expect a release of the schizones for up to 4 weeks. So you need to give the patient this mefloquine for up to 4 weeks. Okay, and only the Plasmodium ovale and vivax had a dormant form in the liver. So you require the primaquine to treat the cases of ovale and vivax. Very important, you need the primaquine to treat the cases of ovale and vivax, because you can expect a dormant hepatic phase, and in this phase they become latent for like year even. So you can expect a reactivation after months or years. Okay, very important to know. So yeah, if they give you a history of a patient from India, you can expect a falciparum, and most commonly you can expect a vivax and ovale case. And in that scenario, you can have a dormant hepatic form. So you will give the patient mefloquine as well as a proguanil. And if it is a patient from the Africa, it is most commonly the falciparum type malaria. Okay, and you will give the patient mefloquine for up to 4 weeks. Okay, so any doubt?
No.
Okay, so we will move for the Babesia. And like I told you, the exotics that the exotics carry the Babesia, the Anaplasma, and the Borrelia. Okay, and Babesia generally causes the flu-like symptoms: fever, headache, joint pain, muscle pain, and they causes the hemolytic anemia. Very important. You will get the hemolytic anemia, and the first symptom would be the fatigue. Okay, and like I told you, because exotics, most commonly the patient came from the Connecticut. Okay, and this infection generally occurs within the United States. Very important. So in case of in case of a plasmodium infection, in case of malaria, if they want you to diagnose the malaria, they will always give you a traveling history or the immigrant history of the patient. Okay, and if they're not giving you any immigrant or a traveling history of the patient, then they're talking about the Babesia. Okay, a very important thing to differentiate, because they both have very similar symptom, right? They both have very similar symptom. They both have the fever, chilling, and this that the hemolysis. But the only way to differentiate between the two is either to look at these ring forms, and if you're not able to look at the ring forms, if the diagram is too much complicated, then you need to look at the history of the patient, if they're having a history of immigrant or not. Okay, if they're having a history of traveling or not. If they do not have any history of travel, or if they do not have any history of immigrant for recent 1 to 2 or 3 months, that means they're giving you a case of Babesia. Okay, and you need to know that in babesiosis, you can even have a ARDS, acute respiratory distress syndrome. So you can have a pneumonia also. So it could be a patient having a history of fever, hemolytic anemia, and the crackles in the lung, and the edema, shortness of breath, chest pain, and chest X-ray infiltrates, hyperdensities. So you can have a Babesia. And on the peripheral belt smear, what you can have is a Maltese cross appearance. okay, which is a 4 ring within 1 RPC. And if they do not give you 4 rings, then you can look at the immigrant status. And the drug of choice would be the atrovaquone as well as the azithromycin. Okay. So that's it. And you can have a raised LFTs, just like the plasmodium. You can have the splenomegaly, you can have the hepatomegaly, just like case of plasmodium malaria. Okay. Any doubt? Then we will move for the other protozoas. Okay, and one is the Trypanosoma cruzi. It has the trypomasticoid, just like the Trypanosoma brucei, and just like that, the C-shape, as you can see, C-shape or U-shape flagellated parasite. They will explain like this: C-shape or U-shape parasite. Okay, this causes a Chagas disease, which causes a dilated cardiomyopathy, and you need to know it causes a thinning of the apex of the heart, and as a result, you have this aneurysm of the apex of the heart. Okay, you have this aneurysm at the apex of the heart. Okay, and when you have the aneurysm in the apex of the heart, you can expect the formation of thrombus in it. Okay, and this thrombus can later on dislodge and become the embolus. So you can have a systemic embolus. In this case, you can have a stroke and you can have a renal necrosis. Okay, and yeah, that's it. And you can also have a megacolon. Okay, megaesophagus. Okay, and yeah, that's it. Most importantly, you can have a cardiomyopathy with the apical atrophy. You can have you will have a thinning of the apex of the heart so that the aneurysm would be formed there. Okay, they will explain you this. And the acute infections generally have a periorbital swelling, which is a very characteristic finding in the acute stage. Okay, periorbital swelling is in the acute state, and the chronic state, what you can expect is a cardiomyopathy, dilated cardiomyopathy. So you can have a this murmur in the heart. You can have and the patient will also have this edema thing inside the body, and the fatigue of the body. Okay, so that's it. And yeah, trypomasticoid, not other things. Any doubt? And you can expect the arrhythmia, and that can lead to the death of the patient. Most important thing is just an aneurysm and the thrombus formation, and after thrombus you can have a stroke. Okay, and you can expect a murmur in the patients, and the arrhythmia can lead to the death, or the stroke can lead to the death. Okay, any doubt in Trypanosoma cruzi?
No, thank you.
Then comes the leishmania. Yeah,
Why were you saying fatty?
why we are saying
I thought you said the word fatty a couple times, but were you referring to?
what word?
Sorry, I thought I heard you saying something fatty. Maybe you said, maybe I misheard. Thank you.
You can please type it down if you want. Please type it. Oh, not fatty, no fatty, no. Okay, then comes the leishmania and their species. They can cause the either the kala azar, which is a visceral leishmaniasis. It affects your organs, or either it can cause a cutaneous leishmaniasis. Okay, so in case of visceral leishmaniasis, because you're affecting your organs, they can affect your liver, can cause a hepatosplenomegaly, they can affect your bone marrow, can cause a pancytopenia. And one of the most important symptom is the spiking fever. You can get the episodic fever after the traveling history. You will have a history of a patient who's you will have a traveling history of the patient, and after returning from the endemic countries like Africa, the patient is having fever for like 6 months or 7 months or up to a year also. Okay, so once you get this kind of a history, you can immediately know that the patient is having a leishmaniasis, a very long history of fevers, and plus the hepatosplenomegaly. Okay, and because you get a pancytopenia, you can expect recurrent infections from different bacteria or viruses. Okay, and in the biopsy of the patient, you can have these intracellular organisms. Okay, having this rod-shaped kinetoplast. They will describe you like that. Intracellular oval parasites having rod-shaped kinetoplasts. They're not showing. You can see this like very likely that show these rods. Okay, these are kinetoplasts. Okay. So intracellular round or oval parasites, and the parasites are in the macrophages. Okay, and they have this kinetoplast, or they can mention the name amastigoids. So trypamastigoids for Trypanosoma cruzi, and amastigoids for the Leishmania. Okay, and they affect the macrophages. They can cause a visceral leishmaniasis, presents with a long history of fever, like 6 months or 7 months. Okay, and this hepatosplenomegaly and pancytopenia, and the patient can have a cutaneous leishmaniasis, which presents as a painless ulcer. As you can see, the patient has a painless ulcer. So whenever you encounter a patient having a history of travel to the Africa or any other region, a traveling history is must, very important. And then he's having these ulcers over the skin. Okay, and on the scraping of this ulcer, you're having this rod-shaped kinetoplast and and this oval parasite. That means they're referring to the cutaneous leishmaniasis. You can easily diagnose it. Okay, and for the treatment, you give the patient amphotericin B and sodium stevogluconate. You need to remember the amphotericin B most importantly. Okay, this is very important drug. So any doubt on leishmania?
Could you repeat the biopsy findings of leishmania?
What findings?
These biopsy findings.
Findings on leishmania, right?
The biopsy findings based on the smell.
I'm actually, you're not audible clearly. Please write and please you can type it in the chat box. Oh, biopsy findings. Okay, biopsy findings. Okay, so on the biopsy, either you can take the biopsy from the ulcers or you can take the biopsy from the liver. Okay, and what you find in the biopsy, you will have this macrophage, as you can see. And within the macrophage, you can see these oval-shaped parasites. Okay, and these parasites have a rod-shaped kinetoplast. Okay. So as you can see, these are the parasites, oval shaped parasites, and these parasites have this rod shaped kinetoplast. I don't know if you can see it. These, is it seeing that rod here? You guys can see the rod here. Should I zoom
Why
it
did
more?
you draw it?
I think you guys are able to see the rod now. Okay, these are the rod shaped kinetoplasts. Okay. Is it clear now?
Yes.
Okay, so now the Trichomonas vaginalis, which causes the vaginitis. Remember the difference between vaginosis and the vaginitis. Vaginosis is not the inflammation, but vaginitis is the inflammation. Okay, and you can also get the Candida vaginitis, and just like the Candida vaginitis, it also has the inflammation in the vagina. So you will have the pain in the vagina, you will have the redness in the vagina, and you will have the pruritus in the vagina. But apart from these things, their discharge is greenish in color. Okay, in case of Candida, you have the whitish, thick cotton cheese-like discharge. In case of Trichomonas vaginalis, you will have this greenish discharge, which is very foul-smelling. Very important, foul-smelling, greenish discharge, and itching would be there, burning pain would be there, and reddishness would be there. Erythematous vagina, swelling would be there. Okay, and do not confuse it with the Gardnerella vaginalis, which is a gram-variable bacterium. Okay. And what you can see is a strawberry cervix or a red inflamed cervix also. Okay. And you also need to know the pH of the vagina in case of vaginalis and the Trichomonas vaginitis. You will have the pH greater than 4.5. But in case of Candida vaginitis, you will have a pH less than 4.5. Okay. And you need to know that it is a STD. Okay. So you need to treat both the partners, the male partner as well as the female partner. But in case of Gardnerella vaginalis, you just need to treat the female. No need to treat the male partner because it is not a STD. But the vaginitis, the Trichomonas vaginalis, is a STD. Okay. What you will see is some, these trophozoites, which are kind of mobile, and have a shape of like coconut. Okay, the shape of like coconut, as you can see. And the step 1 will ask you how will you identify the organisms. So you use the wet mount. Very important, you use the wet mount for it. Okay, so KOH preparation for the Candida, KOH preparation for the Gardnerella vaginalis, and the wet mount for the trophozoites. Okay, and for the metronidazole, as a treatment, you will give both the partners. Okay, the patient and the partner. Okay, very important. Any doubt for the Trichomonas vaginalis?
No.
Then comes the nematodes, their route of infection. I have already discussed it in my own paper. But in case of fecal route, it could be E-ATTT, Enterobius, Ascaris, Toxocara, Trichinella trichuris. In case of cutaneous, which you get from sand, strongyloids, Ancylostoma, and Necator. Actually, you get this infection from sands only. You know, these nematodes, they directly enter in your skin through piercing the skin by walking on the sand naked on the naked feet. Okay, then comes the bites, for which you need to remember the mnemonic low, lay low to avoid getting bitten, and this is a loa, Onchocerca, and the Wuchereria. So now discuss the nematodes, and you need to know that for every helminthic infection there exists a eosinophil. Remember, I told you the function of eosinophils, that are very important to fight against the helminthic infections, because they releases their the major basic proteins, and these major basic proteins are very much important in fighting against the parasitic infections, and that's why in the parasitic infections you have this high eosinophil count. Okay, so whenever you encounter a case of a patient who is having a very high eosinophil count, like 4% or 5%, you can immediately know that he is having one of the nematode infection. Very important. And you also need to know that IgG and IgA takes part in the ADCC, fighting against the parasites. Okay, very important. Whenever you have these elevated eosinophils, always suspect the nematodes. Okay, so first is the Enterobius vermicularis. The route of transmission is by the mnemonic fecal-oral route. Okay, and you have this anal pleuritis. You have this anal pleuritis, and please remember the Scotch tape test. You will put a Scotch tapes, and after looking in the microscopy of this Scotch tape, what you will see is the perianal eggs. Eggs in the perianal regions. Okay, so remember the Scotch tape, remember the anal pleuritis. Okay, and remember the this fecal-oral route, of course. Okay, and for every nematodes that is listed from here to here, you will use the albendazole or any mebendazole or any bendazole drug. Okay, so very easy to remember the name of drugs that you use for the treatment. Then comes the Ascaris lumbricoid, which is the largest roundworm, of course. Okay, it is also acquired through the fecal-oral route. It can enter in your intestine, causing the GI symptoms there. Then from the intestine, it can migrate to your to your lungs, to your nose, to your mouth, where they causes the lung symptoms. So the patient will have a transient pulmonary symptoms and transient GI symptoms. Okay, they will have the shortness of breath, wheezing, spasms, and then they will have the diarrhea, the nausea, the vomiting. Okay, so step 1 will ask you why the patient is having these both and both the GI symptoms as well as the lung symptoms. So you will answer because of the migration of the larva. Okay, ultimately what's going to happen? They will cause the biliary obstruction. Okay, they will cause the biliary obstruction. So you can have a obstructive jaundice also. Okay, and then you can even vomit these worms out from your mouth via vomiting, of course. Then the strongyloids, stratocalis. Okay, and they also gets, and first let's know the names of this. Just a second, guys. Yeah, so for the fecal-oral route, we have discussed the Enterobius, we have discussed the Ascaris. Now we will discuss this Trichinella and then the Trichura, and then we will come for the sands mnemonic. Okay, for the skin. Okay, so now the Trichinella spiralis, and again the fecal-oral route, you will get them by the undercooked meat or the pork, And the only thing that you need to remember that they infect the muscles. Okay, so what they cause is the muscle pain. So whenever you encounter a patient with the muscle pain, and it is somewhat related to the parasite because you have this high eosinophil counts, right? So whenever you encounter a patient having the myalgia and the high eosinophil count, you will always suspect the Tecniella. The only thing that you need to remember. Okay, so how will you diagnose the disease? By doing the muscle biopsy. And what you will do, what you will get in the muscle biopsy is this: the larvae within the muscles. As you can see, these are the muscles, and these are the larvae within the muscles. Very important. Trachiniella, they causes the muscle involvement, muscle weakness, muscle pain would be there. Okay, and high count of eosinophils. Then comes a trichuris, okay, which is kind of either the asymptomatic or the GI symptoms like diarrhea. Okay, and they can also cause the lactal prolapse in the children. I never encountered any case in the step 1, but yeah, just to complete. Okay, so these are the organisms from the mnemonic EAT, and then we will discuss the cutaneous nematodes from the mnemonic SAND. Okay, so first is the strongyloids, Streptocalis, and they basically penetrate your skin, enters there, and then migrate through your skin and enters the bloodstream. Okay, so they can penetrate your skin. Okay, so how will you acquire the infection? By walking barefoot on the on the sand which is infected with the human feces. Okay, so if you walk barefoot on the sand which is infected with the human feces, if you came into contact with the sand which is infected with the human feces, just by walking or by touching it, this nematode can enter through your skin by penetrating it, and because they move through your skin, you can get a serpingeous rash. As you can see, this is a serpingeous rash, and it is formed due to the migration of the larva through your skin. Okay, finally this go to your GI tract, causing the diarrhea. It can go to your respiratory symptom, causing the hemoptysis or the dry cough. Okay, but the most important thing to remember is the fact that they penetrate directly your skin. Okay, and how you can acquire the infection: by walking or by coming into contact by any mean, by coming into contact with the human uh, feces contaminated soil. Okay, and then you also need to know that in the stool examination you can never see the eggs. Very important. Stephen will ask you on this. You will never see the eggs in the stool examination. Okay, if you want to diagnose the eggs, you need to do the biopsy of the intestine. Okay, only on the biopsy of the intestine you can see the eggs. Okay, and on the stool examination you will see the larvae. So they will ask you what you will find on the stool examination. These are the larvae only, no eggs. While for any other nematode, you will find the eggs in the stool examination. Very important to remember the fact. Okay, then comes Steinsilostoma species and the Necator. And the only thing that you need to know about these organisms is just they suck your blood. Okay, and they causes the microcytic iron deficiency anemia. Okay, they causes the iron deficiency anemia by sucking the blood from your intestine wall. Very important. Okay, and just like in case of strongyloids, you can also get the serpingeous rash in case of Necator and Silostoma. Okay, and you also get the infection by walking barefoot on the beach, or might be getting into contact with the human feces contaminated soil by any means. Okay, and you have this thin-walled eggs in them. Okay, very important. The thin-walled eggs, very important. And again, the treatment is the albendazole or any bendazoles. Okay, then comes, yeah, this is sand. Any doubt so far?
Could you explain again the migration of Ascaris?
Okay, so the migration of Ascaris, right? So you ingest this organism through the fecal-oral route, right? It will enter your GI tract, and from the GI tract, it will go to your lungs or or the mouth or the nose, right? So you will have the transient GI symptoms first when the organism enter your GI tract, And then you will have the transient pulmonary symptoms when the organism enter your respiratory tract. So transient pulmonary symptoms and transient GI symptoms. So step 1 will ask you why the patient is having the diarrhea first, and then the respiratory symptoms later, and again then the diarrhea. So it is because of the migration of the larva. Okay, they will list you down the options in like the reinfections, or might be the cross reactivity, or might be other things, and the answer would be your migration of the larva. Very important. Okay, this larva migrates from nose to mouth and then to again the GI tract. Okay, clear now?
Okay.
Okay, then comes the tick bites, the Onchocerca, Loa Loa, and Wuchereria. Ah, yeah, we forgot to talk about the Toxocara, right? Okay, it causes a visceral larva migrans. Okay, just like the cutaneous larva migrans that you see in the Necator and Ancylostoma, you will get the serpiginous rash there. You will have the visceral larva migrans. That means this larva migrates to your organs. Okay, so it will affect multiple organs like your eyes, like your liver, like your brain, like your heart. So in the heart, you can get the myocarditis. In case of CNS, you can get the seizures. In case of liver, you can get the hepatomegaly. In case of eyes, you can get the blindness even. Okay, and of course, it is through the fecal-oral route. So a classical case could be a child who is having a history of coming into contact with the cat or with dog. The soil which is infected with the cat or dog. Okay, then the patient is having the symptoms, the respiratory symptoms. He will having the history of without having history of asthma, he is having this wheezing, and then the hepatomegaly, and then the seizures, and then the heart things. Okay, fever would be there. So Toxocara canis. Then comes the Onchocerca volvulus, and the only thing that you need to remember is black. You will get everything black in this case. You will get the black skin nodules, hyperpigmented nodules, I must say. Scientifically, you will get the hyperpigmented nodule. You will get the blindness, okay, the black sight, and the black fly. So the only thing that you need to remember is black. Whenever you have a black nodules over your skin, you will always think about the Onchocerca, and it will be caused by the bite of black fly. Then comes the Loa Loa, and the only thing that you need to remember is the eye worm. Okay, you can even see the worm in the eye of the patient. So whenever a stem, whenever a question stem describe a case of a patient who is kind of having conjunctivitis, okay, or maybe the blindness, and they will show you a photograph in which they have shown you this, this larva within the eye of the patient. You will always immediately know that it is a case of Loa Loa. Okay, and you can get it from the mango fly, horsefly, or deer fly. So the only thing you remember is the eye worm. Then comes the Wuchereria bancrofti or Wuchereria malai. They causes the lymphedema, and we have already discussed it in the immunology section. I told you will become very, your the part of your limb which is affected will become very heavy, very luxuriant. Okay, and the lymphedema is always non-pitting. Initially, it is pitting, then it becomes the non-pitting after the fibrosis. Okay, and the drugs you should know for the low mnemonic, you will use the dithylcarbamazine or the ivermectin. And for any other organism, you will always use the albendazole or mebendazole. Okay, so for lower Wuchereria only, you will use the dithylcarbamazine. Okay, and for the Onchocerca, you will use the ivermectin. And for any other organism, you will always use the this albendazole. Okay, any doubt so far? And in any of these diseases, you will always expect the eosinophilia. So please look for the labs. They will mention it. They will mention the eosinophil count like 4% or 5%. And you immediately know that the patient is having a nematode infection, because eosinophilia would be there, right? And with the eosinophilia, if you're having the GI symptoms or the respiratory symptom or the skin symptoms, you will immediately know that it is an infection from either of these organisms. Any doubt, folks?
For the Toxocara canis, is the wheezing because of direct damage from the larva or from the eosinophilia?
From eosinophilia also, and because the larva would go into your lungs also. That's why both of
Okay.
the things.
Thank you.
Okay, then comes the cystodes, which are also known as a tapeworm, and like we have listed it already, this includes the Taenia solium, they includes the Diphyllobothrium latum, and they includes the Echinococcus granulosus. So for the Taenia solium, you need to know that it is an intestinal tapeworm and it can cause a cysticercosis, but you need to know how you get the intestinal tapeworm and how you get the disease cysticercosis. If you ingest the larva, please note down the point. If you ingest the larva, then you get the intestinal tapeworm. You will get the GI symptoms like diarrhea. Okay, and if you ingest the eggs, then you get the neurocysticercosis. Very important. And once you ingest the eggs, symptoms won't occur instantly, but instead it will take time. After years later, you will have these seizures. Okay, and on the CT or MRI of the brain, what you will find these cystic areas in the brain. These cystic areas in the brain, and that's why the name cysticercosis. Okay, and you can remember it because they have the shape of eggs. Okay, so by ingestion the eggs, you will get the cysticercosis, and by ingestion the larva, you will get the intestinal tapeworm. Okay, and for every disease that we list here, they will always be treated by the praziquantel. Okay, every cystode and every trematode is treated by the praziquantel except one, which is Echinococcus granulosus. Okay, then comes the Diphyllobothrium latum, which causes the vitamin B12 deficiency, like we already discussed in the vitamin B12 part. Okay, but you need to know that it is acquired by eating the fish. So the fish and the vitamin B12 deficiency, megaloblastic anemia. Okay, treatment again same praziquantel. Then comes Echinococcus granulosus, which causes the hydatidiform cyst in your liver. Okay, it is a cyst that exists in your liver, as you can see in the diagram. And please note down, while doing the surgery, if somehow you get this cyst ruptured, you can get the anaphylaxis shock. So it would be a patient undergoing a surgery of a cyst, some kind of a liver involvement would be there, and then suddenly the patient is died. Okay, and they will ask you why the patient is died. So we'll give the answer anaphylaxis. Okay, and why it happened? Because of rupture of the cyst. Okay, and you need to know that this infection could be acquired by the sheep and by the dog feces. So it could be a patient having sheep as a pet. Okay, or might be the dog as a pet. Okay, treatment again the albendazole, like I told you, and you can see in the MRI, this is a cystic space within your liver. Okay, this is a cystic space, hyperattenuated region in the CT. This is the hydatidiform cyst. And if the cyst rupture, you can get the anaphylaxis. Then comes the trematodes, which are the flukes, and it includes the cystosoma and the clonorchis. Okay, for the cystosoma, you have the Cystosomia hematobium and Cystosomia mansoni. Okay, and for the Cystosomia hematobium, you will get the bladder involvement. You will get the squamous cell carcinoma of the bladder. Very important. The only thing that you need to remember is the squamous cell carcinoma of the bladder. And for that, you will get a terminal hematuria. At the end of the urination, you will get the blood. Very important. At the end of the urination, you will get the blood. So whenever a question is describe a patient having a history of blood at the end of urination, might be painful, might be painless, doesn't matter. At the end of the urination is important. Okay, terminal hematuria they call it. You will immediately think about the Cystosomia hematobium, and they have this terminal spine. Okay, and then this Cystosomia mansoni and Japositicum. Okay, you will get this portal tract involvement. You will get the hepatic fibrosis. Okay, you will get the GI involvement also. Okay, so the only thing that you need to remember is a portal hypertension. So whenever you encounter a case of a patient with portal hypertension and eosinophilia, two things, portal hypertension and eosinophilia, you will always think about the Cystosomia mansoni. Okay, how you will get the infection? By snails, by coming into contact with snails, by bathing or swimming in the contaminated fresh water. So very important, the term snails and the fresh water swimming or bathing. And how will this trematode enter your body? By penetrating through the skin. Very important, by penetrating through the skin. And step 1 will ask you why you are getting symptoms in case of cystosoma. So please note down that it is not due to the parasite itself, but due to the granulomatous response which generated against the cystosomia. Very important. It is due to the granulomatous response, the granulomatous inflammation that is generated against the cystosoma that is causing the symptoms, not the parasite itself. Okay. And the very important thing that you should remember that it is a Th2 mediated granuloma. Okay, Yuval has mentioned it. It is a Th2 mediated granuloma. A very strange thing, you know. Generally, the granuloma is Th1 mediated, like remember if you guys. But in case of cystosoma, it is Th2 mediated. A very odd thing to remember. Okay, and they can also get the intestinal ulcers, so you can get the iron deficiency anemia. Okay, you can detect the stools. You can detect the egg in the stools also. Then the Clonorchis sinensis, which causes one involvement, which is your bile tract. Okay, so you will get the pigmented gallstones, and it can also no, they didn't mention. They didn't explain very clearly why the Th2 mediated. I have already searched it very well in the internet. I have studied the research paper. It's just a fact. You know, it is kind of a strange thing, very odd thing that they have this Th2 mediated granuloma, but it is a fact now. No explanation for it. I've searched everywhere but couldn't find anything.
Can you tell me how does this cystosoma Manson causes portal hypertension?
It is all due to the granuloma. You know, they will ask you why all the symptoms that you are getting in this cystosoma infections, why the symptoms are occurring. So it is always due to the response. Like I told you, this granuloma will not only seal off the organism, but it will also cause the tissue damage. Remember the lesion in the TB, the cavity lesion that you're getting in the TB, it is due to the granuloma formation, right? So similarly, in case of cystosoma, every symptom, every infection, every involvement that you are getting, it is due to the granuloma formation only. Okay.
Okay, thank you.
Then comes the Clonorchis. The only thing that you need to remember is that it infects the bile tract. So it can cause the pigmented gallstones and it can cause a cholangiocarcinoma. Okay, so for the bile tract involvement, for the stone formation, you remember two organisms, which are Ascariasis and the Clonorchis sinensis. And for the cholangiocarcinoma, you will always remember the Clonorchis only. Okay, undercooked fish. Remember one more organism by the fish. You occurred by the fish. Diphyllobothrium that causes the beetle deficiency megaloblastic anemia. Then comes ectoparasites, the Sarcoptes scabies, and you need to know that these organisms actually make burrows in the stratum corneum, and they will lay down their eggs here. And it is because of the eggs the inflammation occurs, and because of the inflammation you get the pruritus. Okay, so in case of a HIV or any immunodeficient patient, you won't get the pruritus. Very important that it is the inflammation which is causing the pruritus. Okay, and if the patient is immunodeficient or HIV, you won't get the pruritus, but you will get the disseminated infection of this Sarcoptes scabies. So you will get the multiple ulcers in the skin, crusting lesions in the skin you will get, but no pruritus because no inflammation. And most commonly they causes the pruritus in the finger webs, as you can see in the diagram. Okay, and they can also affect your armpits, axilla. They can also affect your elbow region. Okay, antecubital area, of course, can also be affected. Okay, flexor surfaces mostly you should know. Flexor of the wrist, flexor of the elbow, flexor of the fingers or the finger webs. Okay, small crusted lesions, as you can see, small crusted lesions would be there, and large crust would be formed in case of immunocompromised patient. Okay, and transmission will always occur through the skin to skin contact. Okay, and in the daycare center it is very common in the children. Okay, and you need to know that pruritus is worse at the night. The patient generally complain first pruritus in the night. Permethrin cream is the treatment that you give. Then comes the pediculus humanus and pethris pubis. Okay, pediculus humanus, as the name suggests, it affects your pedicles, which are foot, and pethris pubis affects your hairs. Okay, it is a blood-sucking lice, okay, that causes the intense pruritus, the joue, the hair lice that you know. Okay, these are the Perthes pubis. So in the pediculus humanus capitis, it is a head lice causing the very pruritus in the scalp. Okay, it is an allergic reaction, and of course, just like the Sarcoptes scabies, it can transmit by just contact, touching, skin to skin contact. Then the Perthes pubis, which causes the pruritus in the inguinal region or the pubic area. Okay, and you need to know that condoms are unable to prevent this transmission because it is due to the skin to skin contact. Okay, so in case of very intense pruritus in case of pubic area, it would be the Perthes pubis. In case of scalp, it would be a pediculus humanus capitis. Okay, and the treatment includes either giving patient ivermectin or the malathion, which kills the parasite. Okay, and the nitcombin. And you also need to know the fact that children with the head lice can be treated at home without interrupting the school attendance. You don't need to stop your children from going school. Okay, you can easily treat this condition at home. Okay, yeah, that's about the pediculus humanus capitis. Any doubt? Please respond. Any doubt?
No, sir. I think we're good.
Okay, then some buzzwords that will help you diagnosing the conditions. If there is a cholangiocarcinoma or any biliary tract disease, it must be colonorchis. In case of cyst in the brain, it could be a tinea, which is neurocysticercosis. How will you get the infection? By ingesting the eggs. Then the hematuria or any involvement of the gallbladder, you will always think about the Schistosomia hematobium. For hydroniform cyst in the liver, it would be your Echinococcus granulosus. In case of microcytic anemia, the blood-sucking worms, which means your ancylostoma and Necator. In case of muscle pain, the only thing you remember is a trichura and this trichinella. Then in case of perianal pruritus, it would be Antrobius. Scotch tape, remember. In case of portal hypertension, it would be Schistosomia mansoni and Japonicum. Okay, in case of vitamin B12 deficiency, it would be a Daphlobothium latum. And we have finished with the protozoas. That's it. Okay, any doubts so far?
No.
Okay, so guys,
could you explain
yeah, please. Ask.
findings of neurocystic psychosis?
Findings in the neurocysticercosis, it's just a seizures only. Nothing else, just a seizures. It would be a patient who ingested the eggs years back, and now after years later, he's having the seizures. And because for every seizure you have to do the MRI, it is a routine thing. Okay, whenever a patient come to your OPD with the history of seizures, you always do the MRI or the CT, and in the CT MRI you will diagnose these cystic spaces, the calcified lesions. These are actually calcified granulomas, or you can say, right, the cystic spaces you will see in the CT or MRI, and that's how you know this must be a case of neurocysticercosis. Okay,
Okay.
just the seizures you will get, nothing else. Any doubt?
No.
Okay, so guys, actually my throat is hurting now, and I think I should stop here. We will discuss the later things this tomorrow. Okay, if you guys are okay with that.
Yes, no problem. Thank you so much.
Okay, thank you.
Okay, so
Yes,
we will
no
stop
problem.
here. We'll wind up
Okay.
here. Okay.
Thank you.